A very good morning to all of you. I welcome everyone to the second KGMU Clubfoot Program 2023, organized by the Department of Pediatric Orthopedics KGMU and Cure International India Trust in association with POSUP, Pediatric Orthopedic Society of Uttar Pradesh. As we all know, clubfoot is downward and inward deformity of foot which affects almost 1 to 2 per thousand live births, and approximately 30,000 children are born with clubfoot every year. That is data from India. It is a major cause of physical disability occurring in otherwise healthy babies. Clubfoot is easily identifiable and correctable with Ponseti method, a highly effective and low-cost treatment. However, like any treatment method, this method requires a basic training and orientation, after which it's easily reproducible with excellent results. So now without any further delay, let us begin with the first session of today. I request Dr. V.S. Gogia sir and Dr. Mayank Mahindra sir to kindly moderate the session. Please come up on the stage, sir.
Very good. Good morning to all the delegates and distinguished guests. I thank the organizers for giving me the opportunity to moderate this session. We have a lot of enlightening talks in this session. The first is by Dr. Vikas Verma on objective of the course and introduction to the program. Dr. Vikas Verma, please.
I take this opportunity to welcome you all to the second KGMU Clubfoot program, which is a skill enhancement refresher course. I have been asked to introduce this course to you. ये slides नहीं चल रहे. Pointer नहीं चाहिए मुझे, किससे चलेगी बस ये बताओ. कहाँ चल रही है? कहाँ चल रही है?
स्लाइड्स नहीं वो हो रही है, वहाँ से ऑफ तो करिए.
So I have been asked to introduce this course and this technique to the delegates. First of all, why this course? Well, the number one reason is the burden of the disease. As per the estimates of the Niti Aayog of the year 2016, around 27,000 children with clubfoot are born every year. And if 1/6 of India's population resides in UP, then that figure for UP would be around 5,400. Since 2016, the population has increased by around 7.6%. So if we extrapolate that increase in population numbers, the figure for India would be 29,000 and about 5,400 for UP. Now that's a huge number. Other independent estimates have put this number to be around 40,000 for India. Secondly, this deformity is not like any other disease. A lot of social issues are associated with it. There's stigma. The parents as well as the children have to face the stigma. Very often the children have to face discrimination at the hands of their neighbors, their colleagues in the schools, and even the teachers. And ultimately it can result in the schooling of the children being affected. Plus, there is associated psychological morbidity. It has been reported that parents as well as children with clubfoot tend to suffer from depression as well as anxiety. It is said that it takes a village to raise a child, which means that an entire community of people is needed to provide for and interact positively with children, for children to experience and grow in a safe and healthy environment. Now that is for any child. For a special child suffering from clubfoot, we need additional support from a team of individuals. That is an orthopedician, a plaster technician, a counselor, a physiotherapist, and an orthotist. The Department of Pediatric Orthopedics was started in the year 2015, and we have been running a clubfoot clinic in the department since the year 2018. The Pediatric Orthopedic Department runs the clinic twice a week on every Mondays and Wednesdays of a week. Around 35 plasters are applied in every clinic, and 10 foot abduction braces are dispensed in every clinic. Now these foot abduction braces are given free of cost to the children, and around 5 tendoachilles stenotomies are done in every clinic. That is just to show the burden of the work that is being done by the Clubfoot Clinic of KGMU. This is a graphical representation of the work that is being done by our clinic. Year on year, there is an increasing trend. Now, this refresher training module was conceived and designed by the faculty of the Department of Pediatric Orthopedics in collaboration with QA International India Trust, who has helped us with the IT and academic resources as well. The first course was conducted in the year 2021. Till date, we have trained more than 200 young caregivers at KGMU. This is a structured course where we will have a pre-test, a didactic lectures. There would be a workshop in which there would be hands-on training on clubfoot models. The audience for the course include the orthopedicians, plaster technicians, counselors, physiotherapists, and orthotists. The stars of our show are these. Now, the objectives of this course is to create a multidisciplinary team, including orthopedicians, plaster technicians, physiotherapists, counselors, and orthotists. We have to describe the pathoanatomy of the condition, to train the participants in treating clubfoot using Ponseti technique, including its use in older children, to describe the common errors in using Ponseti technique, to train the participants in casting technique using a hands-on workshop. Now a word about the Ponseti method. It is a specific method of manipulation to stretch the contracted ligaments, followed by a specific method of serial casting to hold the stretch, followed by a percutaneous stenotomy of the tendoachilles under local anesthesia, followed by a specific method of bracing, and a long-term follow-up for recurrence. Why should Ponseti be used? It's easy to use. It can be done at OPD basis. Physiotherapists, orthotists, doctors, nurses, and even community health workers have been trained to implement it. Secondly, it is effective. There is around a 90% cure rate. 45-year-old follow-up has shown mobile, pain-free, and plantigrade feet. The results are reproducible. There is minimal scarring, and it allows for bone growth. The goals of the treatment are a functional, pain-free, plantigrade, mobile, normal appearing foot in which normal shoes can be used. What should the delegates, the participants focus on? They should focus on the decision making, which is very important in such a complex deformity. It is the key for successfully treating a child. The casting technique, how to and when to use a FAB, it is very clearly defined in the Ponseti technique. How to review appointments, what are the common errors, and what is the role of the counselors. Thank you.
Thank you, Dr. Vikas, for your introduction about this course. And now I would like to call Dr. Santosh George for his talk on Cure India and Achievement in Clubfoot Management. Dr. Santosh George. Sure. should we? So should we go in for the? So since there is a delay with Dr. Santosh, so can we call upon Dr. Prabhat Kumar for his talk on spectrum of clubfoot deformity? Dr. Prabhat.
Good morning, everybody, respected teachers and my colleagues, my juniors, my residents who are here to participate in this beautifully programmed course on clubfoot deformity management. And we are privileged to be a part of this clubfoot deformity management because it's a unique kind of itself program designed and being practiced in northern India for the first time. It has been enrolled and many students from different colleges has been enrolled in this. So I have been given the topic spectrum of clubfoot deformity. There are a few types based on the cause and based on the treatment. So based on cause, it is idiopathic, secondary, postural, as we all know. The idiopathic causes have few hypotheses like musculoligamentous fibrosis, in which there is a hypothesis that due to increased collagen fibers and fibroblastic cells, the ligamentous laxity and the contractures develop. And the other is primary germ plasma defect, which will be dealt later on. And the third one is, the second is secondary. Secondary are those causes which are associated with meningomyelocele or other syndromic disorders. There are multiple syndromes in which like nail patella syndrome, Phelan-Smilden syndrome, dystrophic dysplasia, Streeter syndrome, and other syndrome which are associated along with multiple deformities, including this clubfoot deformity. The third one is postural. Many a times we often encounter kids with deformity, often misunderstood like clubfoot deformity, but they can be passively stressed, and we found a supple foot while examination, and while the kid is resting, it appears like clubfoot deformity, but it's not actually a clubfoot deformity. So based on treatment, we can see that as we are planning, as we have participated in this program, we will see how we'll cast and cure the kids so they are corrected, resistant, recurrent, and untreated. The term neglected has been obsoleted from this Cure India NGO because as we are progressing to a beautiful developed society, we are trying to emphasize on participation of the society, participation of different NGOs to ensure maximum number of participants from the society, so that no kid should be left behind apart from because of the treatment of clubfoot. So idiopathic, as we can see, isolated clubfoot, otherwise normal child. We can see while examining any kid coming to our OPD, we should go for a head-to-toe examination because as we said that multiple syndromes are associated with CTEV. So we should go for a head-to-toe examination, looking for signs of other deformities or any other syndromic findings, which these topics will be dealt later on also. So avoiding repetition of the things, I straightforwarding going for the spectrum. So secondary diagnosis. Neuropathic involves spina bifida or other neurological deficits like meningomyelocele or meningocele, any congenital deformity of the spinous process, nerve roots, or the cord. That is the cord may be herniated from the spinous defective spinous process. These include neuropathic causes, and they are a bit difficult to treat because due to the entrapped neural involvement, we can see that the patients may have insensate foot or may have decreased sensory findings over the foot. So, and other are the syndromic ones are arthrogryposis, amniotic band syndrome. While treating the clubfoot, we will encounter foots like these one. These are called resistant clubfoots. Resistant clubfoot are those which are difficult to be treated under the Ponseti technique. While we go for a Ponseti technique, our aim is to attain a supple foot. But due to a few things like hind or midfoot contracture which persist later on, and because these are the parts of multiple syndromes, so there is the other one is recurrent clubfoot. We we have seen patients in the OPD like presenting with dynamic supination. After completing the course of the treatment, after 2.5 to 3 years later of age, when the kids come to us, we find that while walking, the kid present with dynamic supination of foot, or the equinus which we had corrected earlier to completely may again come with 10 to 15 degree of plantiflexion. So these are called recurrent clubfoots. The untreated clubfoot, which we had earlier discussed. These are the clubfoot which has not been corrected during the infancy, or they had not been presented to any center for the management during their infancy or their childhood. So they directly present at the age of adolescence. But in the next course of this Ponseti technique program, we'll see that the first step in the management of any child will go for the casting technique. So that's the beauty of the casting technique, and for which we have gathered here. So they may present with severe contracture and bony deformity. The dynamic contractures may have turned into the static contracture, leading to the bony deformity. So we have to go for an a la carte procedures, or that will be dealt later on. So the last one is complex clubfoot. These are clubfoot that has been treated with methods other than Ponseti techniques, and may have deformities, scarring, deep medial crease, or we'll see that the plantar fascia is taut, and the treatment will be individualized as per the age of the kid and as per the deformity, and the condition of plantar fascia, the equinus, and rest of the deformities like midfoot, equinus, and everything. So these things will be dealt later on. Thanks. Thank you.
Now Dr. Santosh has arrived, so I now invite Dr. Santosh George to elaborate on Cure India and achievement in clubfoot management. Dr. Santosh, please.
Good morning, friends, and welcome. It's great joy to be here, partnering with KGMU for Cure India. I have to acknowledge and thank the presence of Dr. Ajay. It was his persistent follow-up with us. We could actually strengthen our partnership with the KGMU, and extremely happy that you are here. And even as the director of AIMS Bhopal, he has taken up a lot of efforts to spread the program in the state of Madhya Pradesh. So great joy. And I should also thank Dr. Verma, head of the department, for your support in making this training, not only today's training, which is the 116th training program for Cure India. Yesterday was 115th training program we did at the BHU in Varanasi. Today is 116th. We have another program coming up next month in Mangalore in Karnataka, followed by AIMS Bhopal, Madhya Pradesh. So all these things are possible because of the constant support we get from doctors like you all. I'm also very happy Dr. Alok is here from the Lady Hardinge Medical College, Delhi, and Dr. Suresh Chand is spearheading the Clubfoot program here. But I have to mention the presence of Dr. Matthew Verghese and Dr. Alari Karujis. Dr. Matthew Verghese is the founder trustee of Cure India, and it is his vision that the public health system in India should provide Ponseti method to those children who come to the government medical colleges and hospital. So started this in 2009, January is when we first organized the Ponseti method of Clubfoot management training at the Chacha Nehru Bal Chikitsalayah in Delhi. We expected around 35 participants and we received 85 participants. So that gave us a very positive start. I remember Dr. Alarik, Dr. Matthew Verghese, they all were there. And I always tell them, definitely 13 years ago, they looked different. And in return, they're different. But what has happened in the organization is, today we have 362 designated weekly Clubfoot clinic. Any state in India you go, there is a Cure India partnership program going on. So anyone listening today, if you do not have a partnership, or if you know anyone of your friends, colleagues, serving children with the Clubfoot, and if they look for a partnership, Cure India will be very happy to partner with them anywhere in India. That's number one. Second, the training program. That's the greatest experience for us. More than 7,300 doctors have gone through this training program. So again, in any state in India, any medical college, if you find that there is an opportunity to train more doctors, please let us know. Third responsibility Cure India has when it comes to partnership with the government is to provide brace, Steenbeek foot abduction brace, Steenbeek foot abduction brace. We produce them in a workshop in Delhi where persons with the disabilities are employed. So very high quality but locally made foot abduction brace is made available for all the children. And the fourth one, which is actually to us is a strong pillar of our program, is the committed counselors. They all are sitting at the back there. Their support in each of the clinic is very strong. They follow up with the parents. They document all the treatment progress. They distribute the brace and teach the parents how to do the brace and how to care the children during the bracing. And they also make sure that all these children come back and complete this 5 years of follow-up, which is very important. So started in 2009 with the first training program, where I also remember Dr. Ignacio Ponseti spoke to the delegates online when we had the first training program. And then starting from there, today we are here. And our vision is, a day should come soon in our lifetime that we created a network of centers of excellence across India so that any child born with a Clubfoot anywhere in India should access to free treatment and quality care through Ponseti method for Clubfoot. When we had the Global Clubfoot Conference, many of our senior doctors attended that historic first Global Clubfoot Conference. When the Global Clubfoot Conference was held in Delhi at the Vigyan Bhavan, and we did this in partnership with the Ministry of Health and Family Welfare, we had the Honorable President of India come for the conference. And in that conference, he said, we all should take this as a mission mode. Like how polio was eliminated in India, we should work to make sure that every child born with a Clubfoot get access to treatment for Clubfoot. And he used this term, we all have to make Clubfoot history. So if you look at the logos, of course the Cure India logo is there. You also find another logo that we use. In 2013, when we did the first National Clubfoot Conference, we had the Honorable Vice President came. The theme was, Treat Clubfoot Today. If you know, the polio was eliminated with the theme, End Polio Now. So when Rotary came and partnered with Cure India, we came up with this theme, Treat Clubfoot Today. But when the Honorable President of India came and said, make Clubfoot history, we added that theme and we made it Treat Clubfoot Today, make Clubfoot history. So we follow that direction from the Honorable President of India, and our dream is every district in India. Right now we have 766 districts in India. Every district should have at least one clinic so that parents need not travel to another district to get access. But ultimate goal is parents should not travel more than 2 hours. We have achieved this in few states. For example, in the state of Maharashtra, there are 36 districts. All the 36 districts, there are designated Clubfoot clinic. In the state of Gujarat, there are 33 districts. We are present in 27 districts. You take Kerala, 14 districts are there. We are present in all the 14 states. Not only that, for that state, there are 44 designated clinic, because the Honorable Chief Minister came last December and declared that not even one child should be left without treatment. And in case if a child is left without treatment, there is penalty for the public health system. So they created 44 designated weekly Clubfoot clinic so that parents need not travel more than 1 hour to reach the nearest Clubfoot clinic.
Dr. Santosh, 2 minutes left, please.
Thank you. So I wish all the best for today's deliberation. KGMU is so special because you have established the Clubfoot lab. During the inauguration, Dr. Matthew will hand over Clubfoot training kit. I think we got this, I think the first kit in India, and I think KGMU is going to receive the first kit. Not only that, Dr. Matthew has been working with a firm in Hyderabad to create augmented virtual reality for training doctors on the Ponseti method. That's going to be, I think, the latest, the first in the world. And if everything goes well, it looks like KGMU will again get the augmented virtual reality lab, and we are expecting that. It is taking time. We cannot predict when it is going to happen. We hope that in the year 2023 it should be ready, and we will again meet probably in a much larger level to come and sell that launch of that great technology. Extremely honored to have all this excellent faculty, and Cure India will do everything possible to eliminate disability from Clubfoot in India, and our wish is we do this in our lifetime. Thank you so much.
Good morning, respected seniors and my dear colleagues. Today I'll be talking about the basic principles of Ponseti method. So, phase which included bracing for 23 hours per day for the first 3 months, followed by naps and nighttime bracing until 5 years of age. Technique is different from other techniques. First is the hand position, where you place your fingers, then the mechanism of correction through manipulation, full leg casts with 90 degrees of knee flexion, tenotomy, bracing regime, and less frequent follow-up. Now, how do we know the Ponseti technique works? Basically, it has been validated by several clinical studies with validated long-term follow-up, average 30 years of follow-up, and it has been validated by objective scoring, that is the Pirani score, and it has been validated by several MRI studies also. So this is a study done by Pirani et al. In which magnetic resonance imaging of the congenital clubfoot, which patients who were treated by Ponseti method. With this treatment, all the abnormalities seen on the initial scans either improved markedly or corrected completely. Then there was another study by Cooper et al., which had a 30-year follow-up of 45 patients who were treated with Ponseti technique, and they were reviewed after 30 years of treatment in terms of pain and function compared with the subjects who did not have clubfoot. So 78% patients who were treated by Ponseti technique gained good to excellent outcome, and in the no clubfoot group, 85% had good to excellent outcome. This comparison was comparable in both the groups. Then another study done by Hasenberg et al. in which they compared the Ponseti technique with the traditional techniques. The traditional technique was serial manipulation with or without posterior medial release. In Ponseti technique, in 27 patients matched with 27 patients by traditional kite technique. So the result was, in Ponseti group, 3% patients needed further surgery, while in the other group, 94% patients required surgery. Now, Ponseti versus kite technique, there are numerous studies done, which concluded that the Ponseti technique was more effective, faster, it required less casts, there was movement, and less need for further surgery. So this is one more study which was done by Dept et al., which had a 30-year follow-up of the patients who had posterior medial release for clubfoot, compared with 30 years of Ponseti result. So the 62% had good outcome in the Ponseti group, whereas 4% patient had good outcome in the posterior medial release group. Ponseti successful programs for clubfoot care in many low-income countries has been seen. The correction also needs to be maintained using foot abduction braces. Ponseti method can be applied by non-orthopedic practitioners also. In Malawi, there was 98% of correction rate, and in physiotherapists in UK, there was 97.5% correction rate. The patient's view in Ponseti technique was that in USA, the parents' demand for Ponseti technique. The interviews with parents in Ethiopia, majority were very happy with the treatment. So to conclude, the Ponseti technique is a specific method of manipulation, a specific method of casting, percutaneous stenotomy of the tendoachilles with a specific method of bracing. There is a long-term follow-up for recurrence and a specific method of treating recurrence. The Ponseti technique is the gold standard for clubfoot treatment. It is administered through national programs for clubfoot, and it has the potential to eliminate disability from neglected clubfoot. Thank you.
Thank you, Dr. Faisal, for your enlightening talk. I remember an anecdote from my St. Stephen days when I was working under Dr. Matthew. We had a PMR ward, and one of our orthopedic residents who was from Allahabad, now Prayagraj, he said, oh, there is a full ward dedicated for posterior medial release patients. Later he came to know that it was physical medicine and rehabilitation ward. So anyways, let us go further. Now we have a talk on assessing and scoring by Dr. Sharif Shamim. Dr. Sharif, please.
Good morning, everyone. I still remember last time when first this KGMU Clubfoot program was held, this topic was covered by Professor Santosh Kumar, who is not with us now. I'm just trying to copy his teaching technique. Although whatever we do in our life, everything is regulated by something. Even if we driving, if we drive very fast, at the speed of 140 kilometers an hour, and the speed limit is only 100 kilometers per hour, then you will get a challan of 2,000 rupees. And if you drive very slowly, the guy who is running behind you will say, hey, chalana nahi aata hai kya? Like that, everything is well regulated in our life. So, we have got this scoring system in this Clubfoot treatment program. It is called as a Pirani scoring. Pirani scoring was devised by Mr. Shafiq Pirani, who was a fellow to Mr. Ponseti. So why we should assess, measure, and record? Because we want to know the severity and the stage of the treatment. If suppose somebody has got 4 or 5 casting, his score would be low. If the child has not got any plaster, his score would be higher. To know when to move to the next treatment step, and to know when to finish the treatment. Identify resistant clubfoot or relapse, and accurate records of the child's progress. And it contributes to the research about clubfoot and its treatment. So we have total 6 parameters in which we have 3 mid-foot scores and 3 hind-foot scores. So I would like to have a rubber model, and I would explain it on that only. A Clubfoot. So we have mid-foot score and hind-foot score. Total is 6. In mid-foot score, we have curved lateral border. I would like to, the way to measure curved lateral border is by putting one finger or putting a pen or putting a ruler over the lateral border of heel. If it only touches the heel, score would be very high. Score would be 1. If it touches up to the midfoot, the score would be 0.5. And if it touches the head of the first 50, 0. The second parameter is medial crease. So if on gentle manipulation, if we can see the base of the crease, if we cannot see the base of the crease, score would be 1. If we can see the base of the crease, score would be 0.5. And if we can see multiple fine creases over the medial, this border, medial border, the score would be 0. The third parameter is lateral head of talus. By gently manipulation, we first have to identify the head of the talus. So over the lateral border of the foot, the first bony prominence, what we see is, what we can feel is the lateral malleolus. If we move a little bit in front of that, the second bony prominence that we can feel is the head of the talus. So after gentle manipulation, if this lateral head of talus is not getting reduced, the score would be 1. If it is partially reduced, score would be 0.5. And if it is covered completely by the navicular, then score would be 0. So these are the 3 scores on the midfoot. So here in this diagram, we can see that the ruler is touching up to the head of the 5th metatarsal. The score is 0. It is touching up to the midfoot, the score is 0.5, and it is touching only the heel. The score is 1. In the medial crease, there is multiple fine creases, the score would be 0, and one large crease. But we can see the base of that crease, the score would be 0.5, and if we cannot see the base of that deep crease, the score would be 1. And the third one was lateral head of the talus. If head of the talus is completely covered, score is 0. If it is partially covered, score is 0.5, and it is not covered at all, score is 1. The other is posterior crease. We are going to the hind foot score. We have 3 parameters in that also: the posterior crease, the empty heel, and rigid equinus. So just like medial crease, we have posterior crease also. If there are multiple fine creases, score would be 0. If there is one large crease, but we can see the base of that crease, then score would be 0.5. And if we see a deep crease where we cannot see the base of that crease, score would be 1. The other parameter is rigid equinus. In fully extended knee, if we can dorsiflex the knee beyond the plantigrade position, in newborn, if we do dorsiflexion, the dorsum of the foot can touch the shin. But if that is occurring, score would be 0. If in full extended knee, foot can reach up to the 90 degree, that is plantigrade foot, the score would be 0.5. And if it cannot go up to plantigrade, means 90 degree, the score would be 1. We should remember that this should be measured in fully, and 3 is in midfoot. So we should remember we have to look for 2 points, medial crease and posterior crease. We have to feel for lateral head of talus and empty heel. And we have to measure 2 points, rigid equinus and curved lateral border. Pirani score should be measured and recorded at every visit. Should be done when the patient is on the bracing period, so as to we can see whether recurrence is taking place or not. It is done when the child is very comfortable, when the child is in mother's lap. So this is the recording and assessment sheet of Pirani score. On every visit, we fill these forms. If it's a unilateral deformity, we will fill only right or left one. If it's bilateral deformity, we will fill all the 2 things. It's occurring, we can write it here in treatment complication, like patient is developing sore. Or what happens if suppose score was 3 in the third one and it becomes 4.5 in the fourth one, means score is not decreasing, means it's not improving with the cast. So this is the graphical representation. Here we can see that hind foot score and mid foot score, which is pointed by blue line. So in gradual, every plaster score is getting lower, lower and lower. So hind foot scores almost becomes normal in the fourth cast. Mid foot score becomes almost normal in the fourth cast, while hind foot scores lags behind. So when we can plan that when we have to do tenotomy, if the mid foot score is 0, it means the head of the talus is completely reduced and the hind foot score is more than 1.5. So we can go for tenotomy, but one thing we should remember that when abduction is reached up to 40 to 50 degree, then only we should plan for tenotomy. It doesn't mean that if we have achieved a score that is up to mark for tenotomy and abduction has not been reached up to 40 degree, we should not do tenotomy.
Time is up, Dr. Shamil.
Thank you.
Conclude. Session is open for discussion, for any comments, remarks or queries. माइक दे दीजिए डॉक्टर.
And all of you have these badges, and in these badges fully, and the Pirani scoring done for every visit that the child is coming. Whether it is a treatment visit when the casting is on, or it is a brace protocol visit, the child must have the Pirani scoring. The idea is, we know the progression of treatment is appropriate, and we know if there's an early recurrence. Because early recurrence, treated correctly, no surgery will be required. Early recurrence, delayed recognition, you will have the long-term consequence going to be difficult. So therefore, every visit must have the scoring done. It's a very simple score. It doesn't take more than 10 seconds to do it. With every visit, it's just 10 seconds, you do it, and it's easy.
Thank you, sir. And if there are no questions, may I call upon Dr. Suresh to take over.
Thank you so much, sir. With this, we end the session 1. Thank you so much, Dr. Mayank sir and Dr. Gogia sir, for moderating this session. Before we start session 2, I would request Dr. Mayank and Gogia sir to felicitate the speakers of session 1. I request Dr. Gogia sir to felicitate Dr. Vikas Verma sir. I request Dr. Mayank sir to please give the certificate to sir. Thank you, sir. Session 2 start कर देगा फैजल session 2 करो tea break करो. So before we move on to session 2, I request all the delegates to look up the delegate kit. We have a pre-test questionnaire there. They can fill up the form, and at the end of the session we have a post-test questionnaire, and we would like to have it collected from everybody so that we know how much we gained from the workshop. 10 minutes and we'll join again for session 2. And delegates are welcome to ask any questions during.
सर स्विच करिए.
both of us will do.
Welcome back. We'll start the session 2. For the session 2, I request Dr. Sanjeev Avasthi sir and Dr. Santosh Singh sir to kindly moderate the session.
Good morning. A very warm welcome to all outstation guests in city of Lucknow. In second session, the first speaker is Dr. Alaric Aruzis, who will speak on clubfoot pathoanatomy. Dr. Alaric, please.
Hi, can you hear me? Is the mic on? Yeah. So I'm going to do a little something different because I hate speaking in front of the podium just like Matthew. And I think it's important that we interact because always learning should be a two-way process. I don't think it should be just listening to didactic lectures because very little gets into our head then. We're only looking at the slides and we're not really assimilating whatever we want to learn. So today's topic, which is I'm going to speak on, I'll put the slides up. You can put the slides, I think, just to, is this connected? Yeah, good. So I'm not going to use much of it, but it's good to have it up there. So I think if you're looking at the Ponseti method, the important thing to understand is why does the Ponseti method work? And very often, I don't know how many of you are students here who are going to appear for your MS or DNB exams, but these are common questions asked by the examiner. What is so special about the Ponseti method? Why does it work compared to the previous methods described by Kite and by so many other authors? And unless we understand the pathoanatomy of clubfoot and unless we understand the kinematics of the foot and the subtalar joint, we will never understand how the Ponseti method works. I'm not going to stick so much to the time. Oh, I've got 20 minutes, so it should be okay. I should finish in that time. So I think what we should understand is before we understand the Ponseti method and where we should put our fingers and why the Ponseti method works, we must know a couple of things. One is, what is the special pathoanatomy of a clubfoot? And these models that we have there, I wish we can distribute this to the delegates. Is anyone from Cure here? Someone can distribute these models. Thanks, Suresh. So pass it around behind. So it's good that okay, so try and share this with your colleagues because this is an interactive thing. We should learn and understand, and the best way to do that is by looking at these models and using these models. Okay? Okay, so to begin with, let's start asking a few questions. So if you look at a clubfoot, what are the 4 common things that are present in a club? We look at the pathoanatomy of a clubfoot. What are the 4 deformities that are present? Anyone? Good. So that's called the CAVE acronym. So remember, whatever type of clubfoot you're dealing with, whether it's an idiopathic clubfoot, because you've talked about the different types of clubfeet today, the spectrum of the deformity. So whether it's an idiopathic clubfoot or a secondary clubfoot, whether it's syndromic or it's neuropathic, all of them have the same thing in common, that as far as the pathoanatomy is concerned, all of them have CAVE, which is cavus, adductus, varus, and equinus. Okay? Now to understand that and where these deformities are occurring, we must understand the pathoanatomy of a clubfoot and the normal anatomy of a foot first. Okay? So let's begin by asking you all, how many bones does the foot have? Anyone? Quickly. Yes? 7, 8? So Matthew says the easy way to remember it, the number of letters in the English alphabet. How many? 26, okay? So there are 26 bones in the foot. But if you ask a clubfoot expert or anyone who's dealing with foot and ankle problems, from the purpose of a clubfoot understanding of the pathanatomy, we have only two bones in the foot, the talus and the calcaneopedal block. Because the only movement that occurs in the foot, so all these other joints that are present here and all these little bones that are present here don't matter much at all when it comes to a foot and ankle surgeon or for a clubfoot specialist, which all of you I'm sure are going to be. There are only two bones because there's only two joints that occur in the foot. We're not talking of the ankle joint, okay? So they're not talking about the tibio-talar joint where the movement is of plantar flexion and dorsiflexion. But once you come to the foot, the only real movement that's happening is at the subtalar joint complex, all right? And the subtalar joint complex is an important joint for all of us to understand. And what I'm talking about today is not something which was devised by Ponseti or something that Matthew and I have come up with. This has been known for the last 100 or 150 years. And this is work by several people, especially people from France called Farabeuf, who describe the pathanatomy of the clubfoot and describe the movements of the foot that happen. And if you read some of the textbooks, you can get a bit confused because there's a lot of differing terminology of what these components mean and what are the actual movements, what is supination, what is pronation. See, these are movements that we talk about in the forearm. But when it comes to the foot, people get a bit confused. What do you mean by inversion? What is eversion? What is varus? What is valgus? What is pronation? What is supination? And there's so much of confusion, even among senior people, that I think it's time that today we break through that confusion, all right? And I'll help you to do that, but there should be some interaction from you. So as I said, for us, there are only two bones in the foot, the talus and the calcaneopedal block. Now, the movement that occurs in the foot is at the subtalar joint complex. And if you look at the foot model, try it, or whoever has them with you, the subtalar joint complex again consists of two important joints. One is called the acetabulum pedis, and one is called the true subtalar joint. So if you look at subtalar joint complex, there are two parts, acetabulum pedis and the true subtalar joint. Now, the acetabulum pedis is a very interesting concept. It's been described by Scarpa in 1840. And it's very similar to the analogy of the hip, because if you see the hip joint, we know of the acetabulum there, but when you hear acetabulum pedis, you start wondering where does this come from. So the word acetabulum means a little cup of vinegar, acetabulum, you know, acetic acid, vinegar. So a little cup of vinegar is the acetabulum. And you know in the hip joint, it's formed by the three bones, the ischium, the ilium, and the pubis coming together. And you have the head of the femur, which sits in that little cup of vinegar, which is the acetabulum. And when it's dislocated out, we say that's a hip dislocation. Now, if you bring that same analogy to a clubfoot, that's exactly what is happening. But instead of the head of the femur going out of the acetabulum, here the head of the talus remains where it is, but the acetabulum dislocates or displaces around the head of the talus. And that's happening at this acetabulum pedis. So what is acetabulum pedis really? It comprises of the navicular. Okay, can anyone identify that navicular on the bone which is there in front of you? So the talus, the bone in front of it is the navicular, which is shaped like a boat. And then you have the anterior and the middle facets of the subtalar joint. And connecting them below is a ligament. Anyone knows what that's called? Yeah, the spring ligament, very good. So that's called the calcaneo-navicular spring ligament that supports the head of the talus from below, a very important ligament, all right? So if you look at the navicular, the anterior and the middle facets of the subtalar joint of the calcaneum, the spring ligament, which is the calcaneo-navicular ligament, and the capsule of the talonavicular joint, all of that comprises the acetabulum pedis. Okay, so that's called AP for short. And then the true subtalar joint is the posterior facet of the calcaneum. So if you combine these two joints together, the acetabulum pedis and the posterior subtalar joint, that whole thing is called the subtalar joint complex. And the only movement that's happening in the foot is down and in and up and out. All right, so this is a combined movement that the calcaneum is going through. And that's happening at the subtalar joint complex. So the whole basis of the Ponseti method is based entirely upon this kinematics of the subtalar joint, which we call kinematic coupling of the subtalar joint. So when you hear these words, what does kinematic coupling mean? It actually means that this movement of the subtalar joint complex occurring at the level of the acetabulum pedis and the subtalar joint, where the calcaneum goes from down and in to up and out, okay? And Matthew here has made a nice origami of a boat. And he's going to show that to you, and we're going to ask what that boat really means and why is that significant to a clubfoot. Okay, so that's where we are. Now if you go to the river Gomti, and all of you should do that today evening, you'll see these little boats bobbing in the river, okay? And if you see those boats moving, you'll see what's happening with that boat. And it's a lovely video that Matthew has put up there. That boat is moving in 3 different ways, but all of them at the same time. It's moving in one plane, which is up and down, and we call that in sailors' terms. Anyone knows? What is that called? That's called pitching, all right? So this is called pitching of a boat. And then it moves also from side to side. And what's that called? That's called from a position where it is in inversion, adduction, and plantar flexion, going up into abduction, eversion, and dorsiflexion. And this is all happening automatically. There's nothing you can do to constrain it. It's not that you can hold that boat down and tell the boat only move in one dimension. The boat moves in all 3 dimensions simultaneously, and that's exactly what the calcaneum is doing as it goes from this position of adduction, inversion, and plantar flexion to abduction, eversion, and dorsiflexion. And that's what Ponseti understood through the work of previous people who described this boat thing. And this was described by a person called Farabeuf in 1872. He wrote this book in French, which is called Manuel de Précis Orthopedic. And based on that work, he's the one who described this movement of the calcaneum like a boat in the water. And Ponseti immediately jumped onto that and said, this is exactly why my method works. It's working because I'm moving the disc loop from its position of adduction and inversion and plantar flexion over to the correction of abduction, eversion, dorsiflexion through the kinematics of the subtalar joint because of the kinematic coupling of the subtalar joint. Has everyone understood this? Because this is what the Ponseti method is. Today when you have the afternoon session, when you're going to be manipulating the child's foot, it's all based upon this kinematics of the subtalar joint. And this magic that happens, so now those who have this model with you, watch what I'm doing. I'm putting my finger over the talar head. Okay, so do all of that, whoever has the model. And try and pass it around to your friends as well. Don't hog the model for yourself. And then I'm going to take this lever, which is based on the first metatarsal, and I'm going to start abducting it. Okay? And as I'm abducting it, watch what's happening behind. So the best way is to show to your colleague who's sitting next to you and ask him or her to see what's happening with the calcaneus. As I'm abducting this foot, what is happening with the hind foot? Can anyone tell me what's happening with the calcaneum? The calcaneum is going into abduction, eversion, and dorsiflexion without me touching it at all. And this is what Ponseti understood. This is what Farabeuf had described, where the calcaneum moving at the level of the subtalar joint complex, because of the various ligaments that attach the forefoot to the hind foot, as you manipulate the forefoot into abduction, the hind foot automatically is going into abduction, eversion, and dorsiflexion. This is the magic of the subtalar joint. This is what you cannot constrain. This is what happens automatically when you do this process, and which kite did not understand. And that's why we see the kite method. What the kite method did was he also understood that there's a cave deformity. He understood there's cavus, adductus, varus, equinus. 2 deformities in the forefoot, midfoot, 2 deformities in the hindfoot. Cavus and adductus in the forefoot, midfoot, varus, equinus in the hindfoot. He understood all of that. But he didn't understand the biomechanics and the kinematics of the subtalar joint. So he saw a deformity. He saw 26 bones. Ponseti and Farabeuf saw 2. And that's a big difference. That for us, it's these 2 bones, the talus on one side, and the calcaneopedal block on the other side. If you don't understand that, then you will be thinking back like kite. And kite saw 26 bones, and kite didn't understand the kinematics of the subtalar joint. And therefore, what he would do is that he would apply a plaster, and he said, okay, there's a deformity of cavus, so let's wedge and correct the cavus, and correct and correct and correct. Then he saw, okay, now there's adductus, so let's put pressure over the calcaneocuboid joint and abduct, abduct, abduct by doing wedging plasters. Will it correct the abductus of the adductus of the forefoot? Of course it will. So when we talk of kite's mistake, it wasn't a mistake for kite, because kite said that if I apply pressure to the calcaneocuboid joint and wedge the plasters out, of course I can correct forefoot adduction. But what was the mistake that he didn't understand is that by putting a finger over the calcaneocuboid joint, you're preventing the hind foot from moving. And this automatic correction that happens like the boat is being blocked because you have not understood the kinematics of the subtalar joint. You need to try and break down the deformity into cavus, adductus, and try and correct each one sequentially. That's why Kite took 6 to 9 months and maybe 20 plasters to correct a deformity, which Ponseti could correct in 4 to 6 plasters. So this was the basic difference. And when you talk of Kite's mistakes, is to understand it's not a mistake in his technique, it's a mistake in his understanding of the kinematics of the subtalar joint, because he saw these as separate bones, he saw them as separate deformities. He said, let's correct them sequentially, and it didn't follow the biomechanics and the kinematics of the foot. All right? So if this is clear to you, now you will understand why the Ponseti method works. And people always ask the exam, what's the difference between Kite and Ponseti? Why does the Ponseti method become so popular? Why did it overtake the Kite's method? Because obviously it was much more efficient and much more effective. Okay? There's something happening with my mic, I think. Is that clear to everyone? If there's any questions, you should ask now. Okay? You can ask even later, because you can go back and think this through. And remember, it takes time to understand this, because many textbooks don't mention this clearly. Most of this has now been enunciated by recent foot and ankle specialists like Vince Mosca, who has actually gone down into the core of what the kinematics of the subtalar joint are and why does the Ponseti method work. Mobile phone? No? Yeah, okay, so this is the first principle of why the Ponseti method works, because it's based on the biomechanics and the kinematics of the subtalar joint complex, which occurs around the acetabulum pedis. And the magic of the subtalar joint is as you abduct the forefoot, because of that oblique orientation of the subtalar joint, the calcaneum goes into abduction, eversion, and dorsiflexion. But that's not all. This is the biomechanical part. And we know that obviously in orthopedics, there has to be two parts to everything. So even when we do fracture healing, fractures heal because of biomechanical reasons and they heal because of biological reasons. So the same way the Ponseti method is based on two aspects. It's based on biomechanics, which is what we've talked about just now, and it's based on biology. Now, what is the biology of the Ponseti method? The biology of the Ponseti method is based on the collagen. And we know that all ligaments and all tendons in the body contain collagen. And what's special about collagen? Collagen is something which is elastic. Collagen is something which is stretchable. If it wasn't stretchable like bone, we would never get corrections by pulling on tendons and ligaments. But that's exactly what is happening here. So if you look at collagen under the ultramicroscope, what you will see is collagen is not straight, all right? Collagen fibers are wavy. And what's that wavy appearance called? We are going back to some basic science now. It's called crimp. It's called crimp, okay? So that wavy nature of collagen is called crimp. Now when you pull on collagen, what happens to that wavy fibers? The crimp straightens out, okay? And when that straightens out, that's called another phenomenon, which is called, so we all heard this and we all learned this in basic science, but we've all forgotten this as we go from medicine into orthopedics. Yeah, that's called creep. So when you straighten out these fibers of the collagen, the crimp straightens out, and that stretching is called creep, okay? And what happens with creep? When you stretch that out, the ligaments now and the fibers of the collagen have now become straight, have become elongated. If you let go of that, it will go back again to the same position, like elastic band. You take elastic band, pull it out, it stays like that. Let go of the pressure, it goes back again. So with the manipulation that we are doing the Ponseti method, that's why when we do the Ponseti method, we will talk in the next talk, what does the Ponseti method actually include? It includes steps of manipulation, casting, and tenotomy, followed by bracing. The manipulation phase is very important, because in the manipulation phase, we are taking off that crimp in the collagen and we are getting creep. But creep is something that if you let go, it will go back again. So that comes to the importance of plasters. So what does plasters do now? So when you apply a plaster, that creep which has happened within the collagen will not remain the same. Collagen wants to go back to its wavy nature because that's its nature itself. So it goes back to that wavy nature again. But now that wavy nature is now in the elongated form. And what is that phenomenon called? Anyone? It's called stress relaxation. Okay? So therefore you have a crimp in the collagen. You pull on it, the fiber becomes straight, that's called creep. And then if you let go, if you maintain that position in the lengthened form, the crimp comes back again, and that's called stress relaxation. So based on the biology of collagen, where we are using the principles of creep and stress relaxation, we are using manipulation to get creep, and then we are holding it with the plaster to get that stress relaxation. So when you remove the plaster after 1 week, the collagen is not going to go back again to that same position. It's now become a longer elastic band, back with a crimp. And then again we pull on it, and again we apply a, so it's become longer now. Because if it was not to happen that way, every time we do remove the plaster, it goes back again. Then we remove the plaster again, we pull it, again it gets straight. Again it goes back again. That's not what's happening with collagen. Okay? And that's the reason why the Ponseti method includes these phenomena of manipulation and casting. Because the manipulation is bringing out that stretch in the collagen. It's based on the biology of the crimp, which is causing creep. And then holding it in the plaster is causing the stress relaxation. So now you've got a longer elastic band. So based on these two principles, the Ponseti method works. Okay? And all of this is written beautifully well. If you look up Ponseti's book, it's available as a free download. If you go on the PIA website, the Ponseti International Association website, there's a free download of the book by Ponseti. It's just called Congenital Clubfoot, I think. It's just called Congenital Clubfoot. It's a green book which has about 10 chapters. And chapter 3 or 4 is all about this kinematics and the biology of the collagen. And many of us, when we read that book, we read chapter 1 and chapter 2, which is all about the spectrum of clubfoot, and we go straight away to 4 and 5, which is about manipulation and casting, and the interesting part to us as orthopedic surgeons. And for many, many years, I skipped that chapter 3 or chapter 4, I can't remember which one it is. But that's the most important chapter of that book. I can hear the clock ticking already for me. But I think I'm going to wind up here, because if you've understood these two principles, and we'll go back to that presentation. Yeah. So this is what we talked about. I'm just trying to see if I missed anything out. This is Faraba's principles of kinematic coupling. This is the position of supination of the subjoint, and this is the forefoot. Because of the magic of the subtalar joint, this is the hind foot is going into abduction, eversion, and dorsiflexion. So if you really look at a clubfoot, what is a clubfoot really speaking? A clubfoot is nothing but the subtalar joint in the extreme of supination. So where the subtalar joint has gone to the extreme of supination, that's a clubfoot deformity. And we want to reverse that deformity, and therefore we have the Ponseti method, which gives you that correction. All right? Good. So I'll stop there. If there's any questions, and if you have understood this, I think you've understood the Ponseti method. Then whatever you do in the next part of this session, where we are going to have the casting after lunch, and we look at the little babies and the models, and we'll try and understand where our fingers should lie, and how do we do the molding, and how do we do the manipulation and casting. At the back of our mind, remember that it's based on science. And that's the reason why this Ponseti method works. And that's the reason why sometimes a person who's not trained, and why we spend our times on all these trainings, because we want you to understand that it's not just a mechanical factor. We're not looking at a twisted foot and say, oh, let's make it straight. Okay? The reason why we're getting this 95% success rate, now some of the senior people sitting here will remember that when we were not aware of the Ponseti method, many of us were doing clubfoot castings. When I was a student like you in Wadia Hospital, we were doing about 200 clubfoot surgeries in a year, 200 clubfoot surgeries. All of them we would begin by casting. Ajay, you'll remember, isn't it? We would cast all of these children. Our success rates were like 10% or 20%. All we used to say is that your child has come today, let's start casting. The idea of casting for us was to stretch the skin so that when we did surgery, we didn't have skin necrosis. But ultimately 80% or 90% of our children needed surgery. And why? Because we did not understand all this that I've spoken about today. For us, we looked at a deformity and we said, okay, let's just pull on it to stretch the skin. And then ultimately this child is going to need this very extensive posterior medial lateral release, where we release all the muscles, tendons, ligaments, and make the foot into a loose thing, and then pin them and get the correction. All right? And the reason was because we did not understand these principles of Ponseti. And ever since we have understood that, within 2 years, MSTRs became 200 patients of Ponseti method. And now the number of patients who are really need surgery has become so low, because we have understood the science behind all of this. And that's what I want to impress on based upon this entire biology. Okay? Thank you.
Thank you, Dr. Alaric, for a very enlightening talk. Now I'll request Dr. Alok Sood to please speak on manipulation and casting.
Dr. Alaric, I have never seen the close movement of the boat like this you have shown to us. That was a fantastic presentation.
Yeah, good morning, everybody. Why it is very important to understand kinematics of clubfoot? Because it is very closely related to the manipulation technique. So until unless we understand the kinematics, we will keep correcting clubfoot just like a bent wire on the basis of Cora that over here at the junction of midfoot and hindfoot or midfoot and forefoot, there is a bend, and let us straighten out this bend and this will lead to correction. So this is how Kite understood, and this is how we understood it around 20-25 years back. And that is why we had a lot of JES fixators, we had a lot of PMSTRs, we had a lot of CSTRs to be done. And as Dr. Alaric pointed out, these surgeries are now negligible, right? We do not do any PMRs. I have not done PMR in last 10 years. I have not done any CSTR in last 10 years. I have almost stopped doing any JES fixators. So why this has happened? This has happened because now we have understood the kinematics of the clubfoot. I have 20 minutes or 10 minutes? Oh, okay, 10 minutes. Okay. Thank you. So how do we translate this kinematics into manipulation is the purpose of this talk. Now I'm not going to discuss all this. We already know all this. Now there are three important casting steps to paucity. The cavus is the first of it is the cavus is the correction of the cavus. So why does cavus happen? If I can. Okay, so cavus is basically happening because the hind foot is supinated. You can see in your models, the hind foot is supine. It is looking inwards, right? But the forefoot is pronated, right? So this is a very important principle. The hind foot is supinated, it is looking inwards, whereas the forefoot, it is actually pronated. It is looking outwards, and that results in dropping of the first metatarsal. Because of supination in the hind foot and pronation in the forefoot, there is a rotatory malalignment in between the hind foot and forefoot. Right? So the first step is to correct this malalignment. How do we correct this malalignment? Just by lifting the first metatarsal. So by lifting the first metatarsal, we are supinating the forefoot. That makes hind foot and forefoot, that brings hind foot and forefoot in the same alignment, right? Now once this foot has been, the forefoot has been supinated, the hind foot and forefoot, they are aligned as far as rotation is concerned, and this foot is now ready to be abducted. So that is the first golden rule of paucity, that you elevate the first metatarsal, right? Once this foot is elevated, once this first metatarsal is elevated, and we have corrected the supination, now this foot can be abducted, and as it was being told, calcaneopedis block, it rotates around the talus, right? So the talar head remains stationary, and the calcaneopedis block, it rotates around the talus. So this is the second golden rule of paucity. And what is the third golden rule of paucity? That you do not hold the heel while you are doing any correction. Because if you will hold the heel, whatever natural correction of the varus has to happen, it will not happen with correction of abduction. Got it? So when we are abducting, you can see in the model there is natural abduction of the calcaneum. If you will hold the heel, this natural abduction will be prevented. So there are three golden rules. Number one, correct the cavus by elevating the first metatarsal. Number two, using talar head as fulcrum, abduct the calcaneopedis block. And number three, do not hold the heel. So if you will follow these three golden principles, you will have 100% success rate. Before labeling paucity as a failure, we must look into our technique, that are we using correct technique? are we adhering to the principles? And you will find that if adherence to the principles is done, there is 100% success. So general principles we have already covered. So let us come to the manipulation method per se, right? So what does the manipulation consist of? So manipulation consists of the first move is elevation of the first metatarsal. So when the patient sees you for the first time, you will just elevate the first metatarsal. The foot will appear to be more supinated. The parents may tell you that Dr. Saab I'm using Dr. Matthew Verghese terms, Dr. Saab aapne kharab kar diya. Kharab nahi kiya, right? The moment the parent removes the first cast, he sees the foot and it is really pliable and it has beginning to correct, right? He understands. So the first cast is supinated. It may appear to be more grotesque, but no, this is the first step. So what will happen if you will supinate? Correction. And just look at that. If you will pronate it, first metatarsal, it keeps and the forefoot and hind foot, they lock each other. If there is a, okay. So central to this manipulation is identification of the head of the talus. So where is the head of the talus? So head of the talus is not distal to the lateral malleolus. It is anterior to the lateral malleolus. This is what you have to learn, and you can also teach it to the parents for manipulation, right? So keep your finger or thumb 1 centimeter anterior to the lateral malleolus, and that spherical globular swelling is prominence is the head of the talus. So that is the most important step when you want to manipulate this foot. So where to put your fingers? You put your thumb at the head of the talus and hold rest of the calcaneopedis block by the other hand. And then we start casting. So before I tell you how to cast, let us go on to manipulation method. So for manipulation, you will require 2 people. Can I invite one of the volunteers to hold this foot? It will be easier. What? Anyone? Okay. So I was hurrying actually. Okay. So I want you to stand there. So this is the child, right? And this child, you can hold the, right? So this child has a deformity on the right foot, all right? So this is, when I am treating the child, I'll be facing this child like this. Now for the right foot, I can hold this, are we visible? Yeah. So on the hand. Yeah, so you can just focus on the hand, right? So this is a right foot. I will hold this right foot with my right hand, right? My forefinger is on the first metatarsal and my thumb is on the head of the talus, right? By the other hand, I can hold the leg. I can replace this thumb with the thumb of the left hand and I can produce manipulation, right? So by this method, I am able to not only abduct, but also get some dorsiflexion, right? So this is a 2-hand hold. Yeah. Okay. So I hold the leg like this, place my thumb on the talar head, and with these 2 fingers, I am placing them on the first metatarsal and doing abduction. But beware, do not pronate. Always do abduction in neutral position or in some supination, right? Okay. Now this is a 2-hand position where I am using both the hands. Now there is a single hand position because the child's foot is very small. You will be able to hold the foot in a single hand. So how in a single hand? So these two, my forefinger and middle finger on the first metatarsal, and the same hand, the thumb is on the head of the talus, right? So this is right foot, right hand. This is the manipulation. Got it? But if I have to use my left hand, then I switch. The thumb goes to the metatarsal and the forefinger goes to the talar head. All right? Okay? So suppose now just suppose in your mind that you have a child with bilateral clubfoot and you are sitting here and examining this child and manipulating this child. So for the right, I am a right hand person. So for the right foot, I can do this, right? My fingers are here and this is a slightly bigger model. And yeah. Yeah, you are the child. Yeah. So now you're a smaller child. So these two fingers are on the metatarsal and the thumb is on the talar head. Can you see? And this is the manipulation. Okay? Now suppose it is the left hand side. This is the right foot. Now suppose I have to see the left foot. Now either I can use the left hand or with the same hand, my fingers are now on the talar head and thumb is on the metatarsal. Got it? Have you understood it? So for the right foot, the fingers are on the metatarsal and the thumb is on the talar head. With the same hand, for the left foot, I switch my fingers. But you can use your left hand also. For the right hand, if I use my for the right foot, if I use my left hand, the thumb is on the metatarsal and the forefinger is on the talar head. With the same hand, left hand, for the left foot, I have to just switch, right? So it becomes very simple when you are doing it in the patient, right? It might be a little bit of confusing. Should I repeat or you have understood it?
I think when you do the manipulation, you'll understand.
Right? So two hand and one hand. This was one hand. As far as two hand is concerned, two hand position is usually reserved for the first cast when the foot is quite rigid. So how do you do that? With one hand you hold the leg, okay? I'll come here. Okay. So with one hand I am holding the leg, my thumb is on the talar head. Okay? The other hand, the fingers are used to lift not only lift the metatarsal but abduct it. Okay? Is that okay? So this is how we manipulate it. Now once it has been manipulated, what I'll do is that I'll hold the forefoot, that is calcaneopedis block, and I'll shift my thumb up. Right? Now I have created space for the person who's casting. Right? I have created space for the person who's standing in front of the foot, and he's wrapping and he's casting. Okay, got it? So again, look at it again. The fingers holding the leg, thumb over the talar head, the other hand over the metatarsals, manipulate it, right? So usually in my clinic I manipulate it and then he goes into the plaster room. It is already manipulated, it has already become soft and it is held like this. The thumb moves up and now there is space for casting. Okay? So this is how we do it. So this is the first cast. In the second cast, it has already become quite relaxed. So you can do one hand manipulation or with the other hand. Got it? Okay. So the important thing is the landmark, that is the talar head. The talar head is in front of that is anterior to the lateral malleolus, approximately 10 mm anterior to lateral malleolus and not distal to it. Distal to lateral malleolus, you will find calcaneo-cuboid joint and you will be doing Kite's mistake, right? So the fulcrum has to be Taylor head. So that is the principle of manipulation. Now there are certain points for, thank you so much. So this was what I was talking about, right? The two-hand position, the one-hand position, and using both the hands, right? By alternating your forefingers and thumb, you can use both the hands to manipulate it, right? So we have to, it's a learning process. It is not a long, it doesn't have a long learning curve. You will be able to learn it very quickly if you know the correct kinematics and if you know the correct anatomical landmarks. So the manipulator will hold the foot, right? So over here you can see Dr. Ponseti actually manipulating it. The manipulator holds the foot and your assistant, he will apply the cast, right? The other hand of the manipulator, these are Dr. Ponseti's hands, right? The other hand of the manipulator, the fingers are used to manipulate around the malleoli and around the heel. It is important to produce a good molding so as to contain the heel so that within the cast the foot doesn't move, right? So the molding is necessary, but the molding should not produce any source. So it will take some experience to produce good amount of molding. It should not be very tight, it should not be very loose. And you have to learn to switch over your hands, right? From one hand to another hand so that you can hold the foot in correction and simultaneously mold around malleoli and the heel. The cast has to be a snug cast. It should not be very loose. It should not be very tight. These are general principles. Always use above knee casts, because if you will not use above knee casts, the amount of abduction and external rotation which is intended will not be there, and you will always have suboptimal corrections. So 90-degree of flexion at the knee has to be there so that there is no slippage, and the optimal changing time is 5 to 7 days. So most of us are using 7 days because that is how we work in our clinics. A plaster bump should be left at the end. So this bump will help to remove the plaster. So once you will soften it in water, the parents will find the bump and they can remove the bandage. So that is the tip. For older and stronger children, we can use you can reinforce this cast with the help of a slab, above knee slab. I sometimes also use a below knee slab. And you have to give instructions for the parents, and for this part, I think we are very thankful to our counselors because we do not get time to train the parents to take care of the casts, and our counselors play a great deal of role in training the parents in this role. So don't get the cast wet, don't let the cast get damaged, and look out for potential problems. You have to tell the potential problems, especially if it is the first cast. The cast doesn't slip down. If it slips down, it will get converted into something else. Dr. Matthew will talk about it. The cast falls off, if there is a bad odor. So all these things have to be looked for. So the key message of this talk is it's very important for you to know where you put your fingers. Thank you very much.
Thank you, Dr. Alok. A very good presentation for the manipulation and especially for the casting methods. Now I request to Dr. Madhusudan Mishra for his talk on the common errors in Ponseti method. After that, there will be discussion on these three topics.
Good afternoon, respected chairperson, my senior teachers, colleague, and and delegates. My topic is common errors and troubleshooting in Ponsonby method. Ponsonby method have a specific method for manipulation, casting, tenotomy, bracing, and follow-up. Error in any either manipulation, casting, tenotomy, or bracing may result in the poor outcome. If we never pronate foot during the casting, if we pronate foot during casting, this worsens the deformity by increasing the cavus. In Ponsonby method, thumb must be on the lateral head of the talus, not on the calcaneocuboid joint. So, if finger touching the calcaneum, this blocks the movement of the subtalar joint. This results in the secondary deformity. There is a dictum, only when the foot is fully abducted and calcaneum properly corrected, only when the foot is ready for the dorsiflexion. Before tenotomy, the foot should be abducted from 50 to 70 degree. If failure to fully abduct the foot, this may result in the incomplete correction and limit dorsiflexion and relapse. If we externally rotate the foot without counter pressure on the lateral head of the talus, this may result into the deformity on the lateral malleolus and ankle mortise. Stretching against a tight tendoeclist may result into the rocker bottom foot and flat top talus. So tenotomy is always done when foot should be abducted at least 50 to 70 degree. In Ponsonby method, cast must be from the toe to groin in order to fully hold the correction. If we apply cast below knee, then cast do not hold the calcaneum in abducted position. Poor casting technique. Too much of the padding or not enough molding may result in foot slips upward into the cast and deformity may worsen. So always tell parents to come back immediately if foot disappears inside the cast. This is the example of the too much of the padding or too short cast may result in the slippage. As I already said, pronation of the foot is never advisable. Other casting errors are removing cast one day before. This may result into the relapse. If casting is done under general anesthesia, then general anesthesia is dangerous for baby. There is too much of the risk of the pressure sore. There is a protocol for the foot abduction brace. If the foot abduction brace is not according to the protocol, then clubfoot may likely to reoccur. So work with the family to encourage correct use of the foot abduction brace. If we apply too much of the pressure, then pressure sore may appear. At each visit, we have to score the Pirani so that we can plan for the further management and early recurrence we can note. The never cut plaster. Removal of the plaster is best done by putting plaster in water. So if we summarize, the cast should be from toe to groin. At least 2 people should cast. Follow Ponsonby protocol at each step. Scoring at each follow-up guide as further management. Should be no communication error with the parents. Talk to parents from start and keep communicating with parents. Thank you.
Thank you, Dr. Madhusudan. May I call all the speakers on the dais for the discussions? Dr. Alric, Dr. Alok, and please, I request to the delegates, please, you have a nice faculty here on the dais and you can learn from so many things with them. So please ask whatever query you have. Never shy about what is the wrong, because the questions are never wrong. Answers can be wrong. So you can ask any question, whatever you have in mind, so that the learned faculty can give the answer. So mic please to the third row.
Come the mic.
Please give a mic on the third row, please.
I can ask you a question. can you, who all have used Ponseti method and casted? Please raise your hands.
I think
So all of you, almost all of you have done it. Okay. So when you did it, who manipulated? You yourself manipulated? Yeah. Who was the manipulator? Who was the caster? So there were two people or one person? Two people. So who manipulated? So manipulation is very, very important, right? Manipulation is something very, very scientific. So a person who's trained should manipulate. See, applying a plaster, even your assistant or a plaster technician can do it. But manipulation and holding should be done by a person who's trained in this method. Because until unless you will know correct method of manipulation, correct method of holding, the method is likely to fail, right? And mind you that Ponseti method never fails. Whatever failure is there, it's because of we are not applying the correct technique. We are not adhering to the principles of Ponseti. All right, so it never fails. So you must learn how to manipulate. You must manipulate before actual casting is done, and manipulator and holder must be the same person. And you will see that your technique has reformed.
So how do you realize that it is failing?
See, with each, when the patient comes back to you each week, you will remove the cast and you will score, right? That's how you will see whether it is improving or not, number one. So that is an objective method. But when you become slightly experienced, even before you apply an objective method, you will come to know subjectively that this foot is now correcting. How? The crimp is setting in, the creep is setting in, right? That means it is becoming softer on the medial side and posterior side. And the lateral head of the talus has beginning to disappear, okay? So that is how you will judge subjectively, but obviously for objective assessment you have Pirani score.
Is there any maximum number of casts that you require? They say 6. Is there any maximum number?
Yeah, so Matthew's asking, is there any maximum number of casts? And this is a very pertinent question because when we visit several clinics, we have seen there are some children who have had 20, 25 and 30 plasters, okay? And I think that is not what we should be doing. Now, if you look at Ponseti's recommendations, he described this technique for children who are less than 6 months to a year. And if you are using it for an idiopathic clubfoot in that age group, I don't think we should be crossing 8 plasters. So I think our counselors also have been told that in case anyone finds that in a clinic, a child is receiving more than 8 plasters, we should red flag that. There's a problem either with the technique or there's an actual problem with the foot. So whatever we said so far is for the idiopathic clubfoot. There are syndromic feet, there are neuropathic feet which are more stiff and will need more plasters. But in the standard idiopathic foot in a child who's 6 months to 1 year of age, within 5 to 8 plasters, you should get your correction. If you're not doing that, then there's something to be of concern. So what I would urge all of you, the youngsters who are here, if you're doing casting and you find that you're exceeding 8 plasters for idiopathic clubfoot in a young child, take it up to the next level, show it to your AP or the professor or someone who can then intervene to find out why the number of plasters are going up. But this is not true, of course, if we're talking of syndromic feet, if we're talking of the older child, which we'll have a talk later on. But for the idiopathic clubfoot in a child who's less than 6 months to a year, within 5 to 8 plasters, we should be getting our full correction.
So 100% correction is for idiopathic clubfoot, not syndromic. That's number one.
And sir, what is the ideal time to start the manipulations?
I think Alok, you can.
Yeah, I was just adding to that, to what Dr. Alaric said, that whatever is being said will be true if the casting and manipulation is started as soon as the child is born, right? You will see that with a Pirani score of 5.56, if a newborn is brought to you 3 to 4 weeks, within a single cast, you will see that the score has dropped to 3. And in the second cast, it is almost 0. And by the third or fourth cast, it's ready for percutaneous sternotomy. So the age of the child and idiopathic, I'm talking about idiopathic clubfoot, not syndromic clubfoot. The correction is very rapid.
Ajay had a question.
Yeah.
You ask, then I will ask.
No. I'm just reiterating that in your key performance indicator here, item number 3 says 85% of idiopathic club feet will have correction within less than 8 casts. Less than 8 casts if you're doing it correctly. And if you're exceeding 8, maximum 10, please refer to a senior, consult. Don't keep on applying casts. In idiopathic club, don't keep on doing that. It's a red flag. We want you to, the counselors also should not keep sending it back for casting. Please refer to a senior who is experienced in this technique.
Dr. Alok, suppose we start from the newborn, from the chair side. If we start from the newborn, then is there any gap difference below the 1 month and above? There is a gap difference is different in every plaster when you apply, or there is the same gap difference of 1 week or 10 days is always followed?
There will be two answers to this. It can be rapid also. It can be 5 days also. 5 to 7 days is optimal. But the second answer is logistical, because we are doing it, holding the clinic every week. So it is better for us to do it, to change it every week. 7 days is okay with us.
Dr. Alaric mentioned about the crimp. The crimp returns in about a week's time. Does it return in 3 days' time? No, it doesn't. They have accelerated paucity schedules which have been tried, and the papers talk about 4 to 5 days is the fastest that the crimp will return. So making it shorter than doesn't work. But if you have a short 5-day period or a 4-day period, then there's a clinic problem that sets in. So Monday you do the casting, Tuesday, Wednesday, Thursday, Friday you do the repeat cast. Then Saturday, Sunday, Monday, Tuesday again you come. So you keep changing the dates, which creates confusion. If you have only one patient coming in the clinic and you have a low volume practice, it's easy. In a busy clinic, in a government hospital, it's impossible. So a weekly clinic is better. Can we make it 10 days? Yes, we can. Parents say that, we have to go for a wedding. Can we come on the 10th day? Yes, it is possible. But unnecessarily keeping it 2 weeks is not advisable. We do not want, in fact, the older patient, they say 2 weeks, but it's not necessary. You can manage it in 1 week. The crimp returns in about 1 week.
I think we should come down so that they can start working for the inauguration.
Okay.
So please, all the speaker come downstairs so that we can start the question answer. We will continue with the discussion. So any question from the, please, one by one. And it would be all the speaker, please come forward so that they may ask the question.
My question is to Dr. Arujis.
Who is asking?
I'm Harish.
Sorry, sir.
Dr. Alok, whatever. Is tenotomy a must, or we can skip it if the Pirani score is good?
Sir, tenotomy will come later. I mean, they have not covered the tenotomy, so.
After how many days after birth the cast may be applied?
How early the plastering can be started? This is the question.
So we were taught in a little funny way that if you have a breech delivery and you see the foot has come out and the child has a club foot, you start casting while you're waiting for the head to come out. So what it means is that as early as possible. The advantage for that is, the child has the relaxin hormone circulating in the body. That's the time when the mother's pelvis is relaxed and the hormone also enters the baby. And that same hormone which relaxes the mother's pelvis for birth and delivery also helps the child, because the child also is flexible. All the cranial sutures can mold to allow the child to negotiate the birth canal. So that same hormone
at home in a guarded manner should be started.
So there are children in the ICU, for example. We start the plaster in the ICU itself, in case we know that the child is going to remain in the ICU for the next 1, 2, or 3 weeks. At the same time, my idea is that, people always claim that a baby's skin is very delicate.
Yes.
I don't believe that's true at all, because it's delicate at birth, it's going to be delicate for 2 months and 6 months also, So there's nothing of that sort. It's the finesse of how you apply the plaster. The baby's skin is going to remain the same. All right, so start as early as you can. What I generally believe is that in the first 2 weeks you should start. If for other social reasons they want to wait for a month, also fine, because nowhere is it shown that if you wait for a month, you need more number of plasters. But the earlier we start, the better the right answer. Okay?
Thank you. Sir, second question. Yeah. Yeah.
When pressure sore occur during the casting technique, pressure sore. Then we apply for cast holiday for 5 to 7 days. Then during the cast holiday period, can't hear.
He's asking about the pressure sore.
If
So do we take a cast holiday?
pressure
Yes.
sore occur during the casting technique, and when we giving cast holiday for 4 to 5 days. During the cast holiday duration,
we have
what precautions?
What he's asking that
what
in
precautions
case of
for mother
sore,
and ourselves?
he is
What kind-
asking.
What kind of precaution for mother and ourselves during the cast
I think that
holiday period?
this is another lecture. I think you should wait for that lecture to occur. Then you ask this question, because we should limit our question to the lecture which has been there. So your question will be answered during that lecture. Any other question? Yeah, one by one, and you introduce yourself only, then you ask a question. Yes.
Good morning, sir. This is Dr. Gaurav. Sir, I just wanted to know that while manipulating, is there a checkpoint action? I mean, should it be, it's a baby.
It is very
how
important.
How much pressure should be applied, and to what extent should the deformity be corrected?
It is very important. It's a very good question. Your manipulation and casting of the child. Your hands should be as gentle as possible. A gentle correction is always and quicker correction, rather than a very forcible correction. You don't require force at all if you know about the kinematics of the foot. The whole idea of taking a kinematics lecture before manipulation lecture is this only, that you understand the kinematics, and once you have understood the kinematics, you will be able to produce that creep in the crimp with a very gentle manipulation. So the child should not be crying when you are manipulating. The child should be as comfortable as possible, and at the end of manipulation, when you will look at the toes, they should not be blanched, right? So these are few tips.
Other question from your, yes, you can now ask your question. When to remove the cast? When to remove?
So before the next plaster, ideally. So what is recommended is that in the clinic itself, you keep facilities available. We almost never use a plaster saw unless it's the older child where we put a synthetic plaster. But keep a tub of warm water in the clinic itself where the parents can remove the plaster in the clinic, so that within the next 15 minutes or half an hour, the next plaster comes on. I have no problem sometimes in allowing the parents to remove the plaster at home. So if you have a reliable parent, if you work in a private setup sometimes, it's easier logistically to tell the parents, remove the plaster at home, because it tells me that I can allow the parents then to clean the child up, bathe the child, apply some moisturizer, and then bring the important thing, within the next few hours, the plaster should come off. Never remove it the night before. So the ideal answer in the exam, if someone asking you, it should be just before the next plaster. Practically speaking, if it's a few hours before, done at home by the parents, soaking in water, allowing the child to clean, allowing some moisturizer to apply on the skin, it's fine. In fact, I prefer that, because sometimes I remove a plaster, put the next one, especially over the 4th or 5th plaster, all the dead skin starts accumulating, and that becomes very irritant to the child. So allowing the child to be bathed, allowing the child to be moisturized before the next plaster, if you have a gap of few hours, it's perfectly fine.
I can add over it. This is something which is very good. But if the child comes to me next week with the plaster on, I'll be able to inspect whether the toes have gone inside, whether there was slippage, whether there was any breakage. So if I allow the parent to remove the cast in the hospital, just before the next cast, all this examination is possible. Otherwise, the mother or the parent may not be able to tell me whether the toes disappeared or whether it was an effective cast or not. So always there are two faces to a coin, always.
Dr. Alok, there are many parents who sometimes ask for the fiber cast to be applied because they are fond of wearing colors. So what is your opinion, what they should take the...
I will never encourage that because, you know, number one, the fiber cast cannot be removed at home. So suppose if there was blanching of toes or cyanosis of toes, or the child is unnecessarily crying, that means that there is some sore forming. So what will the parent do? If the parent is coming to me to daily from Mathura, I mean, there is no way he can remove it. But if it is just a POP cast, she can just put it in warm water and it can be removed. So I'll not encourage it at all, right? And I'll appeal to you not to encourage it, right? And you will have to use a plaster saw to remove it, which will scare the child away, right? So next time it will cry double the amount because it knows now a big machine is going to come and it is going to make a noise. So unnecessarily it will scare the child.
You want to add something here?
That if your cast numbers are going up and you've not had a practice of seeing your cast before the cast is removed, you will always find either slipped toes or you will find broken plasters or plasters which are totally battered by the children that are older. This will happen in our clinics which are older. It is not there in the classical American textbooks. These are patients which are older who are crawling around, who are trying to walk, and they come with broken plaster which are absolutely useless. So if you're calling se pehle agli bari humko dikha ke jana.
Yes, next question. Yeah.
Myself, Dr. Utkarsh. My first question is, sir, up to what a maximum age with the abduction also should be done?
Good question, again will be answered in that talk. So stick on for that. And following on that, I'm going to ask you a question. Because when I spoke about kinematics and I said that the entire foot is supinated and a club foot is the subtalar joint in extreme supination. And then Dr. Alok came next and said that the forefoot is in pronation. And we have to lift up the first metatarsal to correct the cavus. And not one person got up from the audience and said, Dr. Alric said something different and Dr. Alok said something different. So I want you all to start thinking because we should be thinking surgeons. We should not apply anything blindly. So ye pronation kahan se aa gaya? When we said just now there's supination of the foot because a club foot is the subtalar joint in extreme supination. And Dr. Alok, first commandment he gave you is that the foot is in pronation and therefore you have to lift up the first metatarsal and bring it into supination. Jab ye already supination mein hai. So how is that happening? Anyone? Any smart girl or boy? Yes. Why? Because we just said there's a calcaneopedal block and there's only 2 bones in the foot. So wo kahan se aa gaya? So you're right in that way. So this relative pronation of the forefoot with respect to the hindfoot is a deformity within the calcaneopedal block. Okay? Why is that happening? And for this, if any of you has access to Vince Mosca's book on foot deformities, he explains it very nicely. All foot deformities are not just a club foot. Every foot deformity is a torsional deformity. If you can hold this. Okay? Every foot deformity. So what happens in a foot? A foot is a tripod. All right? We walk on a tripod, which consists of the calcaneum, the first metatarsal, and the fifth metatarsal. Now, when you have a deformity, let's say that the entire hind foot goes into supination, which is what a club foot is. Okay? The tripod is now disturbed. To restore the tripod, the forefoot has to go back into a torsional position to restore that tripod. And that's why you understand all deformities of the foot are torsional deformities. And Vince Mosca talks of taking a towel and twisting it. So if you have a club foot, the hind foot is in supination, but to restore the tripod, the forefoot is in relative pronation with respect to the hind foot. If you have a planovalgus foot, it's exactly the opposite. The hind foot is in pronation, but the forefoot is in relative supination with respect to the hind foot. So whenever you're correcting foot deformities, and this will last you for life, whether you're coming to study club foot or you're coming to understand the foot and ankle, that's what I want you all to understand. That the kinematics and the biology does not change. It's all the same.
So today you're not only going to learn about clubfoot, but you're going to learn about the pathoanatomy of all deformities in the foot which work the same way. That if you understand that concept, that the first plaster that we're talking of is we are untwisting that towel. We are making that into now a planar deformity. We are converting that torsional foot, which is in relative pronation with respect to the hind foot, to now bring it into supination. And how much of supination? Because I've seen people, where's that clubfoot model? Who, the most severe one, that is the mild one, the most severe one. Yeah, that one. Yeah, this one. So I've seen people who say, Dr. Alok ne bataya ki you have to supinate the foot to bring it, to correct that cavus deformity. So they do this. We are not interested in hyper-supinating. What are we doing? We are untwisting the towel, and how much of are we lifting that first metatarsal to bring it in line with the hind foot? That is all. So this deformity that we are doing is to correct the torsion which is there in the calcaneopedal block. It's a deformity within that calcaneopedal block that we are lifting up that first metatarsal, correcting that relative pronation of the forefoot with respect to the hind foot, which you correctly said, and bring it in line with the hind foot, and we stop there. We are not doing hypersupination. We are just doing this. Okay, and when you do that and lift that first metatarsal up and bring it in line with the hind foot, it's now a longer foot. This is what the first cavus correcting plaster is all about. Okay?
Yeah, next
Thank you,
question.
sir.
Yeah. Dr. Afsar.
Sir, as we all are agreed that we
Keep it near your.
We have to start casting as early as possible. Even in earlier discussion it was we can start in ICU. What's the wrong if we do start casting after 3 months or 6 months, and what are the advantage over it?
I want to know the advantage of waiting for 3 months. You give me the advantage of waiting for 3 months, I'll tell you what is wrong with waiting for 3 months. Why do you want to wait for 3 months?
It's not comfort. We are going to do in ICU and start casting.
No, leave the ICU out. ICU is a very rare patient. I gave an example. In my practice and all of us, what we say is that the first few days the child has jaundice, other situations, clear it all up. Once that is cleared up, the child is in the best optimum position right now. Why wait for 3 months? What is going to happen in 3 months to that child which will make things easier for you? It will make it more difficult. So now I'll tell you why I don't wait for 3 months. Because you haven't told me why you want to wait for 3 months.
Sometimes low birth weight.
That's rare situation. So let's not take that 1%. Let's look at 99% of children. 99% of children are fine. The 1% we leave out in the rare situations, I will agree with you. But in the 99% of children who are fine, there is no advantage in waiting for 3 months. The disadvantage is what? You now have a child who is going to be cranky, who has a personality now, because all of us who are fathers and mothers will know that a 2-day-old child is the easiest to comfort. You give them milk, you give them
goes the growth of the bone.
Be in a village, in a house with a deformed.
Not apply.
It will get. I think it helps in.
From and then you have to go on a case-by-case basis. Because even within the idiopathic group that we call, there's difference in severity, even within that group of idiopathic. So when you come to syndrome, that's an entirely different ballgame altogether. So when you say syndromic, it sounds like one word, but there are 300 or 400 syndromes which are associated with clubfoot, and all of them have got different types of responses to conservative treatment. So there are some where it is very supple, and though we say syndromic, the foot can be corrected fully. There are some who are so stiff that they're hard like rock, and you can give 20 plasters and you're going to go nowhere with them. So the answer is, for all types of club feet, whether they're syndromic, neuropathic, idiopathic, all of them deserve treatment with the Ponseti method first. Only severe arthrogrypotic amyoplastic children.
The deformity in the knee itself, which you are trying to correct, like in AMC. But that becomes a different scenario altogether.
Any other question? One question was asked when I was PG appearing for the examination. The club foot is basically a bony pathology or a soft tissue pathology? What is the answer of that? It was asked during my examination.
Soft tissue.
How many for the bony? How many for the soft tissue? How many for the bony?
Now no one will put.
Nobody will speak. How many for soft tissue? Many. Sir, what is you have taken the morbid anatomy.
Yeah, I think the correct answer is both. It's a combination. So always whenever you are in doubt, The correct answer is both, and that's actually the true answer.
But
so we understand that there are problems within the cartilage as well as in the soft tissue. Because if you look at, I didn't put up that one slide which has Ponseti's dissection of a stillborn with a clubfoot. That's a beautiful dissection that he has done, where he has shown very clearly that even if you strip out all the soft tissues from the foot, the bones also are slightly deformed. The talus also has an increased angle of declination.
Yes.
The navicular is not the normal boat shape, it is wedge shaped.
Yes.
So there are bony changes and there are soft tissue changes. What is important to understand is that clubfoot is not an embryonic malformation, it is a developmental deformation. It's a very big difference. A congenital, yeah. So if you say a radial club hand is a embryonic malformation, that means part of the bone is not formed. A clubfoot is a fully formed foot. There are some changes in the bone, some in the soft tissue, but it's basically a developmental deformation. It has happened after everything has formed. It happens in the third trimester and afterwards. So everything has formed. It's not like a spina bifida, it's not like a tibial hemimelia, it's not like a radial club hand, where bones are missing, where there's an embryonic malformation. This is a well-formed, fully developed foot, which then undergoes a deformation for whatever reasons we don't know. And there are germplasm theories behind it, there's vascular theories behind it, there's environmental theories, there's pressure theories behind it. So all sorts of theories behind it. But remember, if you remember these two words, it's not an embryonic malformation, it's a developmental deformation, which means it occurs after the third month of pregnancy. It cannot occur in the first 2 or 3 months. Okay, every bone is formed in a clubfoot. It's just that they're slightly malformed and they have soft tissue contractures.
So next question, which is...
So you answer that or not, Ajay, when you gave your exam?
No.
Because you got gold medal, so you must have given the right answer.
For me, its primary pathology is bony, and the soft tissue changes occurs according to the whatever the bony pathology is there in to correspond that pathology. That you have very well described that the calcaneal pitch is decreased. The neck, the body of the talus and the neck of the talus angle is decreased. It is in plantar side. So the primary pathology is, and now with the evidence of the genomics, we are seeing that there are many genes which are affecting the development of. So primarily, for me, primary pathology is bony pathology, and the soft tissue pathology is corresponding with the bony pathology. That is my, that was.
I think you have published a paper.
Yeah, I published that paper also. Number 2, where occurs the equinus? Very basic question. At which joint equinus occurs? I mean, this should be given by you people, not by us. Sorry? TBO? TBO tell us. How many agree and how many disagree? Or want to add something else also? Everybody. Yeah, you disagree? You? TBO teller, you agree with this answer? Anybody who disagree with this answer?
My answer is always middle path. It's always both. So where's the equinus? Dominantly occurring at the tibio-talar joint.
Yes.
But don't forget that there is an equinus occurring at the subtalar joint
Yes.
as well. We already said, remember the boat in the Gomti?
Right.
The boat has gone pitching downwards. So the subtalar, the calcaneus is also in equinus, not only at the talus level, tibio-talar level, but the calcaneus is also pitched down. So there is a combined equinus coming small amount from the subtalar joint, but predominantly from the ankle joint.
And in continuation, also at the mid-tarsal joint, because the first metatarsal is plantar flex in comparison to the mid. I welcome our Honorable Vice Chancellor, Lieutenant General Puri sir, and Pro Vice Chancellor, Professor Vineet Sharma. So with this, we are ending this session, and
Sir, I'll request to felicitate the speakers of this session before we move on to inaugural program. I request Professor Ajay Singh sir to felicitate the speakers of session 2.
I have 12 questions for the PGs, so I will ask during the lunch hours.
Yeah, there only, sir. Dr. Elric sir, please come up for the felicitation. Sir, there only. No, we'll continue, sir, that discussion. Dr. Alok Sood, sir. Dr. Madhusudan Mishra. Thank you so much, Professor Ajay Singh, sir. Ladies and gentlemen, we have our chief guest of today's program, Honorable Vice Chancellor KGMU, sir, Lieutenant General Bipin Puri, sir, in the hall. So without further delay, we shall start the inaugural program. I request all the delegates to kindly take their seat. So indeed, it's my proud privilege to welcome you all, Society of Uttar Pradesh, POSAP. At the outset, I request our chief guest for today, Honorable Vice Chancellor KGMU, Lieutenant General Bipin Puri, sir, to come on the dais and take his seat. I request Dr. Vikas Sharma, sir, to accompany sir. Next, I would like to call Pro Vice Chancellor KGMU, Professor Vineet Sharma, sir, to kindly come up on the dais and take his seat. I request Dr. Vikas, sir, to accompany, sir. I request guest of honor, Professor Ajay Singh, sir, Director AIMS Bhopal, to please come up on the dais. Dr. Vikas, sir, to accompany Professor Ajay, sir, to the dais. Next, I request to call guest of honor, Dr. Santosh Singh, sir, Secretary UPOA, that is Uttar Pradesh Orthopedic Association, to please come up on the dais and take his seat. I request Dr. Vikas Sharma, sir, Head of the Department, Pediatric Orthopedics, KGMU, to please come up on the dais and take his seat, sir. Next, I would like to call Dr. Santosh George, Director, International India Trust, to come up on the dais and take his seat. Next is Dr. Syed Faisal Afaq, Organizing Secretary of today's workshop and Assistant Professor in the Department of Pediatric Orthopedics, to kindly come up on the dais and take the seat. Thank you, all the dignitaries. It's an old saying that don't judge each day by the harvest you reap, but by the seeds that you plant. So perhaps the achievement for today is not just this gathering, but is also the training, guidance, and motivation which we aim to impart to our younger colleagues and young orthopedic surgeons. With this spirit, I request Dr. Vikas Sharma, sir, to kindly greet our chief guest, Honorable Vice Chancellor, sir, with the planter. I request Vikas, sir, to kindly present the planter to Pro Vice Chancellor, Professor Vineet Sharma, sir, and welcome him. I request Vikas, sir, to kindly present the planter to guest of honor, Professor Ajay Singh, sir, and welcome him officially. Now I request Dr. Faisal to present planter to Dr. Santosh Singh, sir, Secretary UPOA, and welcome, sir. Dr. Faisal to kindly do the honors for Dr. Santosh George and welcome him on the dais. We have many seniors among the crowd present here, but I would request Dr. Faisal to kindly welcome our esteemed teachers, Dr. Matthew Varghese, sir, with a planter, Dr. Elric Arojis and Professor Alok Sood. for coming in this workshop. Thank you so much. With this, we move forward. Goddess Saraswati symbolizes the light, knowledge, and truth. The best way to start this program is indeed to seek her blessings. I request all the dignitaries to please come forward for the lighting of the lamp ceremony. Thank you so much. As we move further, I invite Dr. Vikas Verma sir, Head Department of Pediatric Orthopedics KGMU, to present the welcome address.
Good afternoon, everyone. Greetings from the Department of Pediatric Orthopedics. Today is a proud moment for the Department of Pediatric Orthopedics as we hold the second refresher course on Ponseti management of Clubfoot. I take this opportunity to welcome our Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri, who has been kind enough to grace this occasion. He has been awarded Param Vishisht Seva Medal and Vishisht Seva Medal by the Government of India for his services of the exceptional order. He has been instrumental in setting up the Department of Pediatric Orthopedics at KGMU and has supported us and encouraged us at every stage of our journey. Whatever little we have achieved has been possible only because of his blessings and his spirit of utmost devotion to work. I take this opportunity to welcome Professor Vinesh Sharma sir, Pro Vice Chancellor of KGMU. Sir, the super specialities of orthopedics like pediatric orthopedics, spine, sports medicine, and arthroplasty have developed as a result of your long-term vision to develop orthopedics. We look forward to your continuous support and encouragement. I welcome Professor Ajay Singh, Director AIMS Bhopal, who is the founding HOD of the Department of Pediatric Orthopedics at KGMU. Sir, the department owes its creation to the hard work that you put in for years together. We are proud to be a part of your dream. We know that even if you are not with us physically, we can count on your blessings, support, and constant encouragement. Sir has played a major role in putting up pediatric orthopedics at the national stage and in the consciousness of the medical administrators of India. It is only because of your tireless efforts that the Department of Pediatric Orthopedics has been granted permission to start MCH in pediatric orthopedics, and we have already admitted 3 students in our MCH course this year. I welcome Dr. Santosh Singh, Secretary of Uttar Pradesh Orthopedic Association and a surgeon par excellence who has encouraged us with ongoing academic collaboration between the department and the UPA. I welcome Dr. Santosh, Director of Cure India. He has been serving the most vulnerable children across India for the last 25 years. Cure India is a national voluntary organization that he and Dr. Matthew Verghese initiated and led from its inception since the year 2008. The goal of this unique initiative is to see India free of disability from Clubfoot. Cure India, with the leadership of Dr. Santosh, has signed agreement with several states in India, and 93,000 children are enrolled in this world's largest Clubfoot program. I welcome Dr. Matthew Verghese, a distinguished alumnus of Maulana Azad Medical College, Delhi University. He is currently head of the Department of Orthopedic Surgery, St. Stephen's Hospital, Delhi. A former director of the hospital, he is also adjunct faculty at the Transportation Research and Injury Prevention Program at IIT Delhi, which is a WHO collaborating center. He has trained over 7,600 doctors from government hospitals and medical colleges on a pro bono basis. He is also a founding member of Independent Council of Road Safety International. He is Regional Technical Advisor for Disability and also Regional Technical Advisor for Road Safety at the Southeast Asian Regional Office of the WHO. I welcome Dr. Alaric Arugis, Honorary Consultant Pediatric Orthopedics at the Leelavati Hospital, PD Hinduja Hospital and BJ Wadia Hospital for Children, Mumbai. He has undergone fellowship training in pediatric orthopedics at Alfred I. DuPont Hospital for Children, USA, and National University of Hospital, Singapore. Despite his vast experience in the method of clubfoot treatment, including soft tissue and bony surgeries, and the use of external advocate of Ponseti technique, even in older children. Cure International India Trust is a registered NGO with the goal of eliminating disability caused by clubfoot across the country by enrolling and giving free treatment throughout the 360 designated clinics spread over 28 states and 3 union territories of India. Clubfoot Clinic at KGMU was started in the year 2018. The clinic is run on Mondays and Wednesdays of every week. In the duration 2018 to 2022, 756 children have been enrolled in the Clubfoot Clinic, 5,633 plasters have been applied, 469 tenotomies have been done, 298 foot abduction braces have been given, free of cost. As a part of future planning, Cure India International Trust and KGMU have signed a Memorandum of Understanding to establish a Clubfoot skill lab in the Department of Pediatric Orthopedics, KGMU, with the objective to train orthopedic surgeons serving in the district hospitals of Uttar Pradesh. I welcome Professor Ashish Kumar of the Orthopedics Department, who is also serving as the HOD of the Department of Sports Medicine. I welcome Dr. Gogia, Dr. Mayank Mahendra, Dr. Sanjeev Avasthi, Dr. Harish Makkad, Dr. A.K. Gupta, Dr. A.K. Srivastav, Dr. Amit Singh. I take this opportunity to welcome Dr. Prabhat Kumar, Dr. Sharib Shamim, Dr. Madhusudan Mishra, and Dr. Amitosh Mishra, faculty for this refresher training course. And I welcome all the delegates, members of the press, and volunteers who have encouraged us with their presence in this refresher training. Thank you.
Thank you so much, sir. I would now request Dr. Santosh George from Cure to say a few words.
Honorable Vice Chancellor, Pro Vice Chancellor, sir, the Director of AIMS Bhopal, the Head of the Department of Pediatric Orthopedics and other respected sir, and the faculty and all the delegates. I stand here to thank every one of you for making Cure India successful and to bring us to this level. I remember the day when I met the Honorable Vice Chancellor. When we signed the agreement, he inspired us, encouraged us to further our service in the state of Uttar Pradesh. He in fact very clearly said that quality of the care in the government institutions should be as equal or much better than any other institution. So we were so inspired. And we took the discussions further. We had the discussion of making KGMU as a center of excellence for Clubfoot when Dr. Ajay Singh was here. And at the same time, we also had Dr. Vineet Sharma. Dr. Vineet Sharma has been helping us from the time we signed agreement with KGMU. I think it was 2014 when we first started the program, but then later the pediatric orthopedic department took the lead. And it's in fact a matter of great satisfaction that an institution and an organization can come together to this level and take this program to the next level. We'll be handing over a training kit, 766 districts. And as what the Honorable President of India said, soon we should create a network where every child born with a clubfoot is given compulsory and complete treatment. And it is possible. We're also happy Rotarian Ajay Saxena is here. Rotary, Government of India, all the state government and premier institutions like KGMU. When we all come together, our dream will definitely come true. Thank you so much.
Thank you so much, sir. Next, I would like to request Dr. Santosh Singh, Secretary.
डिस्टेंस को ढूंढ रहा था कि मैं क्या करूं। उस समय डॉक्टर विनी शर्मा ने मुझसे कहा था कि तुम पीडियाट्रिक ऑर्थोपेडिक्स में जाओ, वहाँ पे कोई कंपटीशन नहीं है। तो मैं उसी में गया। 2008 से मैंने काम करना शुरू किया। 2011 से एक्सक्लूसिव पीडियाट्रिक ऑर्थोपेडिक्स का मैंने शुरू किया। और उस समय गवर्नमेंट ऑफ यूपी ने हम लोगों को लगभग उस समय 2011 में लगभग $2.25 करोड़ हमें दिया था यूनिट बनाने के लिए, पीडियाट्रिक ऑर्थोपेडिक यूनिट विद इन द डिपार्टमेंट ऑफ ऑर्थोपेडिक्स। और हम लोगों ने वो 20 बेडेड यूनिट उस समय बनाने का काम शुरू किया। फिर 2016 में हम लोगों ने पीडियाट्रिक ऑर्थोपेडिक्स को सुपर स्पेशलिटी रिकॉग्नाइज कराने के लिए उस समय MCI होता था, अभी NMC है, तो MCI को हम लोगों ने लिखा और उनको ये कन्विंस कराने के लिए मुझे वहाँ एक PG सब कमेटी होती है, उस PG सब कमेटी में द हेड वाज यूरोलॉजिस्ट। और वो जब मैंने ये मेरा प्रपोजल गया तो वो हंसने लगे कि पीडियाट्रिक डॉक्टर साहब जो लोग करेंगे वो कुछ कमा पाएंगे कि नहीं कमा पाएंगे। तो मैंने कहा कि नहीं सर, 30% ऑफ आवर ऑर्थोपेडिक प्रॉब्लम्स आर ऑफ पीडियाट्रिक ऑर्थोपेडिक्स, और ज़रूर करेंगे। मैंने ये भी बोला था कि जो हमारे MS के एग्ज़ामिनेशन होता है उसमें लगभग 60-70% जो केसेस रखे जाते हैं वो पीडियाट्रिक ऑर्थोपेडिक्स से संबंधित होते हैं। तो चाहे वो टीचिंग ट्रेनिंग हो, चाहे क्लिनिकल प्रैक्टिस हो, सीखने वाले को कहीं प्रॉब्लम नहीं होगी। आई एम फॉर्चुनेट कि उन्होंने मेरी बात को सुना और उन्होंने रिकॉग्नाइज़ किया। 2016 से शुरू किया था। 2018 में उन्होंने NMC ने MCH को एक सुपर स्पेशलिटी बनाई। पहली बार इस सुपर स्पेशलिटी बनी इंडिया में ऑर्थोपेडिक्स की। शायद 7 या 8 महीने लगे मुझे गवर्नमेंट ऑफ यूपी को कन्विंस करने में सिर्फ, और उन्होंने एक नया डिपार्टमेंट क्रिएट कर दिया, डिपार्टमेंट ऑफ पीडियाट्रिक ऑर्थोपेडिक्स विद 5 फैकल्टी मेंबर एंड 45 सपोर्ट स्टाफ इंक्लूडिंग नर्सेस। तो एक मेरे लिए बहुत अचीवमेंट था। फिर उसके बाद उसके बाद लेफ्टिनेंट जनरल पुरी सर आए और हम लोगों ने काम करना शुरू किया कि कैसे MCH का काम हम लोग करें। हाँ, इसी बीच में प्रोफेसर विनी शर्मा की मदद से हम लोगों ने फेलोशिप इन 1 ईयर फेलोशिप इन पीडियाट्रिक ऑर्थोपेडिक्स शुरू की थी। और उसके बहुत सारे मेरे फेलोज़ यहाँ पे हैं और आई एम सो हैप्पी कि उसमें से काफ़ी लोग जो हैं वो कहीं ना कहीं असिस्टेंट प्रोफेसर बन के लगे हैं। तो ये मेरे लिए सम्मान का और बहुत ही सेटिस्फेक्शन का है कि मैं जब इनको देखता हूँ तो मुझे लगता है कि वास्तव में मैंने कुछ किया। तो सभी लोगों का बहुत बहुत धन्यवाद कि आपने मुझे यहाँ बुलाया और आपने ये मौका दिया। यहाँ आने के बाद मैं कभी भी, जैसे विकास ने कहा, मैं दूर रह के भी यहाँ के बारे में हमेशा नज़र रखता हूँ, मतलब बुरी सेंस में नहीं, अच्छे नज़र रखता हूँ। और जब भी इनको ज़रा सी भी कुछ ज़रूरत महसूस होती है मैं हमेशा गाइड करता हूँ और मेरे जो भी छोटे मोटे रिसोर्सेज हैं उनसे मैं इनकी हेल्प करने की कोशिश करता हूँ। सो ये मेरा अपना घर है और शायद जब तक मैं हूँ जीवित ये मेरा ही घर रहेगा। तो इसलिए मेरे को यहाँ आने में कभी भी कोई कष्ट नहीं होता है। मैं एक और चीज़ जो मैं बताना चाहता हूँ, जो मेरा एक सपना था, क्योंकि मैंने इस पीडियाट्रिक ऑर्थोपेडिक्स के मूवमेंट को बहुत पास से देखा है। जो अभी फ़िलहाल नेशनल बोर्ड ऑफ एग्ज़ामिनेशन ने एक
एक FNB नया FNB शुरू किया है, फेलोशिप कोर्स इन पीडियाट्रिक ऑर्थोपेडिक सुपर स्पेशलिटी, और हैप्पी कि ये भी दिन हम लोगों को देखने को मिला। और अब शायद जो हमारा डॉक्टर एलरिक यहाँ पे हैं वो जानते हैं कि जब हम लोगों ने शुरुआत किया था तो हम लोग कितने लिमिटेड पूरे इंडिया में 400-500 लोग, 450 लोग हम लोग, मतलब जब मैंने ज्वाइन किया था तो 400-450 लोग थे, और अब धीरे धीरे ये एक सपना हमारा जो है वो होगा। तो बहुत ही अच्छी ये बात है। लेकिन मैं प्रोफेसर विनीत सर से एक रिक्वेस्ट करूँगा, और प्रोफेसर आशीष भी हैं, आने वाले समय में उनको भी इस चीज़ को देखना होगा कि शायद डिपार्टमेंट ऑफ आर्थोपेडिक्स और डिपार्टमेंट ऑफ पीडियाट्रिक आर्थोपेडिक्स का जो आपस में जो मेल जोल है वो बहुत ज़्यादा होना चाहिए, ख़ास तौर से स्टूडेंट की टीचिंग ट्रेनिंग के लिए। और स्टूडेंट्स ऑफ आर्थोपेडिक्स को हमारे यहाँ से मेरा मतलब डिपार्टमेंट ऑफ पीडियाट्रिक आर्थोपेडिक्स में और फ्रिक्वेंटली आना चाहिए टीचिंग ट्रेनिंग और क्लासेस में, जिससे कि उनकी ट्रेनिंग कंप्लीट हो सके। क्योंकि कहीं ना कहीं मुझे ऐसा लगता है कि कहीं थोड़ा सा बीच में गैप हो रहा है। तो मुझे उम्मीद है कि सर आप लोग इस बात का ध्यान रखेंगे, और ये मेरी एक रिक्वेस्ट है, पर्सनल रिक्वेस्ट, कि आप इस चीज़ को आगे रखें। डिपार्टमेंट ऑफ पीडियाट्रिक आर्थोपेडिक्स ने बहुत अचीव किया है, और आज की जो टीम है यहाँ पे वो काफ़ी मेहनत कर रही है। और हम लोगों ने सिर्फ पेशेंट की जो पेशेंट केयर है उसी में हम लोगों ने अचीवमेंट नहीं किया, साइंटिफिकली भी हमने बहुत सारे पेटेंट्स लिए हैं। यहाँ पीडियाट्रिक आर्थोपेडिक्स डिपार्टमेंट ने हम लोगों ने बहुत ही पेपर्स छापे हैं, और पेपर्स भी हम लोगों ने क्लिनिकल पेपर्स, रिसर्च पेपर भी छापे हैं। उसके साथ साथ हम लोगों ने बेसिक साइंसेस को कैसे कोरिलेट करना चाहिए क्लिनिकल साइंस से, उस पर भी हमने पेपर छापे हैं। और अभी फ़िलहाल डॉक्टर सुरेश को भी एक बेस्ट पेपर अवार्ड यूपी आर्थोपेडिक एसोसिएशन में मिला। तो ये अचीवमेंट्स जो होते हैं ये बहुत ही फुलफिलिंग होते हैं। मैं आपका कोलैबोरेशन जो आर्थोपेडिक KGMU से चल रहा है, और मैं आप लोगों से ये अपील करना चाहता हूँ कि एम्स भोपाल में भी हम लोग वी आर वर्किंग ऑन टू मेरी बात हुई है ऑनरेबल CM साहब वहाँ के जो हैं शिवराज जी से, और जो स्वास्थ्य मंत्री हैं प्रभुनाथ चौधरी जी, उन्होंने हमें ये प्रॉमिस किया है कि वो पूरे जिस प्रकार से यूपी में हम लोगों ने ये जो ट्रेनिंग का प्रोग्राम जो गवर्नमेंट डॉक्टर्स हैं उनके लिए शुरू करना है, वैसे ही हम लोग शुरू कर सकते हैं, मेकिंग द एम्स भोपाल एज अ सेंटर ऑफ एक्सीलेंस देयर, and we can spread the knowledge to each and every government doctor. So I extend the invitation to Cure International to come forward, and so that we can do at state of MP also. And I am very happy to just to share that एम्स भोपाल में हम लोगों ने जो एक गवर्नमेंट ने हम लोगों को परमिशन दी है सेंटर ऑफ प्रिसीजन मेडिसिन को शुरू करने के लिए, जिसमें हम लोगों ने आर्टिफिशियल इंटेलिजेंस और सिमुलेटर्स के साथ हम लोगों ने काम किया है। तो जो लैब आप लोग है, हम लोग वही लगभग वैसी ही चीज़ या सिमुलेटर्स के माध्यम से हम लोग we are starting the teaching training at our center, and that would be the center of excellence for precision medicine at AIIMS Bhopal. So it's a very fulfilling journey for me, and I'm really very happy to be here. Once again, I am really grateful for calling me here. Thank you very much.
Thank you so much, sir. Thank you so much for those inspirational words. Now I invite Professor Vineet Sharma, sir, Pro Vice Chancellor, KGMU, and Head of Department Orthopedics, to come and say a few words. Sir.
Thank you, Suresh. Honorable Vice Chancellor, Lieutenant General Vipin Puri ji, my colleague, Professor Ajay Singh, Director AIIMS, Dr. Santosh, Dr. Vikas Verma, Mr. Santosh George, and Syed. My fellow colleagues sitting there, honored faculty, most of them are my friends and my juniors, my students, ladies and gentlemen. Pediatric orthopedics has developed well, and I must give all the credit to Professor Ajay Singh, who has taken it to these heights. Not only the first MCH that has come up, along with FNB in DNB, but also he wants to make it an art, a subject with a difference, with an excellence. And this department that has been created, maybe the direction may be mine, but it is his hard work and his persuasion that has brought us all here. I remember 2005 was talking about whenever a case with not neglected clubfoot, I'll say, but DDH or Perthes or any other congenital scoliosis, deformities of the spine used to come to us, we used to think of a center where to send him. And fortunately, today, we are at a place that we love to teach such children and they are getting magnificent treatment. Now this training that you people are getting today, especially Clubfoot, part of it has been happening over this training has increased leaps and bounds in
I think Dr. Matthew will explain.
Thank you so much for this opportunity. We have this workshop where we want everyone to be skilled. And the saying goes that the devil is in the detail, but we say the God is in the detail. Detail of understanding the nuances of the kinematics that you heard in the morning, nuances of placing your hand at the right place, and these children are very delicate. You treat them with absolute gentleness. So before you touch those children, you have to have hands-on skills. And this is the complete set, the state of the art. Just we received it last year in Cape Town in November, and the manufacturer is MD Orthopedics, the person who was with Dr. Ponseti for a lifetime. So every one of these training kit material has been prepared with the direction of Ignacio Ponseti. It's a very complete set with all the models of the cast, the training models for the rubber models, and the brace, and the large model for the foot, the small model for the smaller child practice, and the brace, and including a tenotomy practice model, what to look for. Everything is there. So we believe, I think when we got the set and when the request came for we thought this is a center, the university, it's a good center where this can be given over as a training skill lab for our pediatric fellows and MCH programs here. So thank you for the opportunity. Santosh, you can add.
No, I should also thank Dr. Vikas Verma for constantly following up with this. We really wanted to do it. And of course, Dr. Suresh Chand also kept on reminding us. And then we are very glad that we could get this entire set. And this is actually first time in India. So it's coming to KGMU first time. And the experience from here, the feedback from here will help us take this center to all the universities. And that's our desire. So thank you so much for accepting this.
No one else in India has this.
And the next level is the augmented virtual reality lab. So that is because it's first time in the world, it is taking time. Dr. Matthew is working very closely with the IT professionals in Hyderabad. But again, when it comes, we promise that KGMU will have the first augmented virtual reality lab for Ponseti method. So thank you so much.
Thank you so much, everyone. Now, I request Chief Guest of the workshop today, Honorable Vice Chancellor, KGMU, Lieutenant General Dr. Vipin Puri, sir, to enlighten us with his words of wisdom.
So, good afternoon, friends, ladies and gentlemen. It's such a pleasure to be here for this very important second Clubfoot program being hosted by the Department of Pediatric Orthopedics of KGMU, in collaboration, of course, with this Cure International. So, we are very happy to be associated with Cure International, seeing all that they are trying to do as a part of giving it back to society at large. But let me begin by talking a little bit about the Department of Pediatric Orthopedics. We're very, very proud. The first, of course, the head of department, Professor Ajay Singh, who's here, the founder. Very, very happy to see how the department is unfolding in time, and it was, of course, his dream, a passion for him to try and take this specialty forward. We're very happy that it's been able to see the light of the day, and in a very short period of time, even begin an MCH program, which itself is, you will agree with me, is not easy when you starting an academic program of this nature. But the fact that KGMU has it all, you have the infrastructure, you have the workload, you have the patient population, and you have the faculty. So actually it wasn't so difficult, but then the issues were of curriculum and et cetera, which Professor Ajay Singh worked. He worked very hard to make all these things actualize, and I sincerely compliment Ajay for doing a wonderful job. We're very, very proud today that he is now the director of AIIMS Bhopal, and we wish him good luck and times to come. Well, friends, there are lots of residents here today. I'm very glad that we have orthopedic residents also here, and I was telling Professor Vineet as well as Vikas that Clubfoot is a very important congenital anomaly, and even in general, I don't know, I'm sure in orthopedics you all show it in your general orthopedics, you show it as a short case, but in general surgery we used to show Clubfoot as a short case. And I'm talking of yesteryears when I was doing general surgery. It is in those times we used to get these cases of Clubfoot, and Clubfoot used to be a very hot topic for us to. And the Ponseti procedure, of course, itni detail में नहीं हम जैसे आप लोग इतनी detail में कर we just knew the overall aspects. What was very commonly talked about, or the different joints that we Clubfoot, where you talk about all the three different types of joints where different movements have to be addressed. Now, those were the things that as a general surgeon that used to be addressed. But today, friends, and this is for the residents, things have become so advanced that you are actually manipulating, maneuvering, navigating every step of your the Ponseti procedure. So I think it's gone up in advancements by leaps and bounds, and I think it's important that we go through these training camps, and these training camps are going to change. We were trying to look at the incidence of Clubfoot, and we're talking about the idiopathic Clubfoot. We're not talking about the paralytic, the myelodysplastic ones. It's 1 in 1,000 live births. Now, 1 in 1,000 live births is huge. If you look at it from, it may not be very severe, but 1 in 1,000 live births having
reduced completely. And it has been found that the tendo Achilles heals completely, and within 3 weeks it is as good as before the tenotomy. So there is no risk of healing issues. So what are the indications for tenotomy? In the morning lectures, we have understood all the pathoanatomy and how to do manipulation and casting. So after we do serial casting and we do Pirani score at each visit, the midfoot contracture score should be less than 1. The talar head should be completely reduced and it should be 0. Hindfoot score should be more than 1. That's where the rigid equinus is, and it requires a tenotomy. So the ideally in most of the cases midfoot score should be 0, but sometimes the medial crease is 0.5 or it is still there, it is not 0, but the talar has been completely reduced and we are getting more than 50 to 60 degrees of abduction. In those scenarios, midfoot score of less than 1 but not 0 can be taken as indication for tenotomy. Of course, the hind foot is not dorsiflexing adequately, that is less than 15 degrees of dorsiflexion, and there should be, as I have mentioned, more than 50 degrees of abduction, and due to calcaneal pedal so these are a few indications of tenotomy in an idiopathic fleet, and a very cost-effective method. We require a regular antiseptic like a betadine or any scrub, gloves of appropriate size, local anesthetic for injecting. It should be without ADR, and a small gauge needle, scalpel, depending on the choice of surgeon, 11 number or 15 number blade, and the blade holder number 3 or so, and gauze and mild sedative, which might be controversial in case of older children, but infants do not require any sedation, and we should avoid that on a daycare basis. This is complete set as I have mentioned there. So it can be done in any aseptic precaution environment. It doesn't necessarily need a proper OT. In our minor OT or a procedure room in OPD basis can be utilized for this procedure. We need 2 people, a primary assistant or doctor should be there, and a junior doctor or any technician can be there to help you. Spine on the table, on his back. The ankle is in maximum possible dorsiflexion so that tendo Achilles is a little bit taut. We can paint the area with small gauze. Not necessary full leg is to be painted because it's very safe surgery and we are working on the soft tissues only. So there is negligible risk of infection considering the basic asepsis precautions. We can paint the area and we can that much of antiseptics is also acceptable. Infiltrate a small amount of local anesthetic over the tendochilus region subcutaneously. Obviously, aspirate a little bit to confirm that you are not in from medial side. So the structure at risk is posteromedial neurovascular bundle, the posterior tibial artery. So we enter just medial to the tendoachilles, and we go anterior to tendon, and it is the blade is rotated. As we have stressed the foot, the tendoachilles is taut. So we just have to put knife over the taut tendoachilles. It will cut on its own. Like the bow and string, we can imagine the tight string in bow. If it is just touch with a sharp knife, it will just give way. So that is what we have to perform here. But due care to the anatomic structure should be given. So the blade is rotated posteriorly to cut the tendon. Be careful that your blade doesn't come out of the skin. If it happens, it's not of much significance, but we may avoid this to avoid any scarring and post-operative large hematoma. So small entry site is helpful in controlling the hematoma. So here is a video where I am doing a tenotomy. So I have holded the leg in foot in taut position so that the tendochilus is tight, and I am entering the blade from the medial side, and I'm just turning the blade. You can see that the tendon gives way, it pops, and I am feeling the physical discontinuity or the gap in the tendon, which confirms the completion of the tendoachilles. So I'll just run this video again. So it's very simple procedure if we take care of all the anatomic landmarks. The amount of local anesthetic should not obscure your finding. Just rotate the blade gently, and the taut tendon cuts on its own, and completeness of the tenotomy is checked with the palpable gap in the tendochilus area, and we should be able to get more than 15 degrees of dorsiflexion in most of the cases, more so in the infant idiopathic club feet. So judging a successful tenotomy, as I mentioned, there will be an audible pop or sudden give way, and able to achieve dorsiflexion more than 15 degrees and a palpable gap, as I have mentioned. You can palpate with your fingertip, right? For the purpose of tenotomy. So some don'ts of tenotomy: do not take entry from the lateral side. Like, so for supra, the proximal tibial pin we put from lateral side, because the structures at risk are at the lateral side. So we enter from the area of danger. Similarly, the concept is here, we enter from medial side. So never put your blade from lateral side, and it should be at the appropriate level, 1 to 1.5 centimeter above the calcaneal tuberosity. It should not be too high or too low. Too low will damage the calcaneal tuberosity, or the tendon will be cut at its insertion where the healing is not so good. And if we go too high, it will be cutting at the muscular area, so the purpose is not solved. The correction will not be achieved as it should be done. Never do in prone position. Sometimes people do it in prone position to control the baby, and one assistant is just grabbing the child so that he cannot move and he cannot resist. So that is not recommended, and it should be done in supine position. Prone position changes your anatomical landmarks. So sometimes we have heard reports of doing tenotomy on the wrong leg, because the right leg was affected and patient was taken prone, and you have done the left side of tenotomy, and because the patient was prone, you could not assess how much of dorsiflexion was there and how much equinus was there. So do it in supine position, just externally rotate the legs and do some dorsiflexion so that tendon is taut, and you just put the knife from the medial side. Too much of local anesthetic will obscure your anatomical landmarks, and sometimes we apply cast immediately after tenotomy. So we should wait for at least 5 to 7 minutes so that the local hemostasis is achieved. Achieve hemostasis, it stains very large amount of area, and the parents are apprehensive about this. So these are don'ts of tenotomy from my side. So apply a gauze and hold the bleeding for 5 minutes, apply the cast in maximum dorsiflexion. So appropriately done tenotomy and applied cast should have this picture in an infant. The dorsiflexion should be more than 15 degrees, and the external rotation should be at least 50 to 70 degrees.
Dr. Suresh,
yes,
please try to finish.
Yeah. And the final of tendo Achilles, and there have been well-studied reports utilizing the MRI that the tendo Achilles is regenerated as quick as three reports of infections and reports of a very large amount of bleeding from the tendo Achilles, and we have never heard a report of push-off weakness or tendo Achilles incompetence after the tenotomy in Clubfoot. So it's safe to do tenotomy in Clubfoot. Thank you so much.
Thank you, Dr. Suresh, for wonderful presentation. Now I invite next speaker, Dr. Amitosh Mishra. He will speak on Clubfoot braces.
First of all, I am grateful to organizing team of Department of Orthopedics KGMU for giving me this opportunity to present this topic. My topic is foot abduction brace. Achieve a pain-free, supple, and plantigrade foot. Abduction brace. So what is bracing starts at the end of casting. The foot is when fully corrected, but it has a stubborn tendency to reoccur. Bracing is essential to maintain the cast and prevent reoccurrence. There are many types of foot abduction orthosis or braces. We commonly known about Dennis Brown all the patients. Brace holds the foot in corrected position, prevents reoccurrence, and it is an essential component of in these foot abduction braces in and 15 degree of dorsiflexion. In bilateral case, normal side is of 40 degree of external rotation in neutral position, 1 inch wider than the width of shoulders. Medial side of a posterior cut, the design of this low posterior aspect of the heel counter prevents the heel to slip out of the heel counter, the better. In high top shoes, when strong leather is used, it encourages the heel to slip out of the shoe. Let me explain this with this. This is a inspection hole on the medial side of the shoe. So, what is low heel counter? In a shoe whereby the height of the heel leather reaches the level of the anatomical angle or just below, the heel can be lifted by plantar flexion. Whereas in high heel counter, the heel leather reaches above the ankle at the posterior side. Plantar flexion will cause the upper end of the heel leather to move anterior and create a posterior point of fixation that will act as a fulcrum against which the child can pull up the heel. If it repeats few times, the brace will be off. So what is the bracing protocol? It should be start immediately after last cast is removed. For first 3 months, 23 hours per day. Brace can be removed for 30 minutes in morning and evening for bathing and stretching. After 3 months, up to age of 4 to 5 years, brace to be worn at night for 12 hours and in the middle of the day when the child sleeps, that is nap, for 2 to 4 hours, for a total of 14 to 16 hours per day. The most common cause of reoccurrence in child on Ponseti regimen is non-compliance with the bracing protocol. There are many studies on this, so foot abduction brace is very effective. Dorsiflexion. So fit the foot abduction brace immediately after the last cast removal. Shoes should be unlaced, gently hold it in the position with one hand and then push the foot in the foot abduction brace. Close the tongue of the shoe and check whether the heel is still in the corrected position through the inspection hole. Keep the foot in position with the same hand and lace the shoe with the other hand. It may need a second person first few times. Brace must be laced up firmly so that the foot cannot be moved inside the shoe. Ensure that the heel of the foot touches the insole of the shoe using the inspection hole. Fit the other foot in the same way. Check that both the heels are visible through the inspection hole. This is a child with foot abduction brace after fitting foot abduction brace. So what are the possible reasons for not using the foot abduction brace? The baby does not like it or it cries. Takes time to put it on and off. The feet already look better. Difficult to carry baby. People might laugh at me or on my child. The child can't move around easily. The baby is difficult to clean. Bracing can be difficult, especially in early stages. It is important that the parents understand why must use the brace and the potential consequences if they don't. Parents should be feel supported. So, instruction for parents, consistency is the adherence, is the key to adherence. Bring the child back if the clubfoot starts to reoccur. Watch the patient, watch the parents how they fit the brace and correct any mistakes. Teach them stretches, kicking patterns. Advise them to look for red marks, blisters, pressure sores, and cold toes. Inform them of their next appointment and ask if they have any questions. Parents should be aware of these complications. Teach them if the brace gets small, the child toes curl beyond the edge of the shoe. Make sure they know the importance of wearing the brace properly to prevent reoccurrence. Inform them as to do the procedure if the foot deformity recurs. So the brace review schedule is 1 to 2 weeks after the first fitting, 6 weeks to ensure compliance, 3 months interval until the child is 2 years old, and then 6-month interval until 4 to 5 years. Review more often if compliance seems to be an issue. So early detection minimizes the severity of reoccurrence. On brace reviews, check the brace fitting, ask the parents how it is going, watch the child in standing and walking, score the fit using the Pirani score, fill in the relevant paperwork, fit with a new brace if needed, and make a date for the next review. Most bars are not strong enough for the child to stand in them, so check angle of bar at each checkup. Curling of toes beyond the edge of the shoe is indication of foot abduction brace is getting too small. At frequent brace reviews, in follow-ups, check how the brace is fitted when the parents bring the child. Is it tight enough? Is it the heel down? Are the feet still at the correct angles? Ask if they have any problems with the foot abduction use. Ask the parents
going to slip. It will be one cylinder. Cast may slip, and if the cast slips, how does the parent know? The toes tell them just अगर वो अंदर गायब हो रही है, उंगलियां गायब for a 1 is a danger sign. You know that you are in for trouble. You know that this is a slip cast. The parents may not have observed it. You may certainly realize that. Secondly, this angular portion of the cast, this presses onto the dorsal venous arch, and what you have edema, because dorsal venous arch is the only draining portion for the dorsal skin. So you have edema on the foot, and recognize it and give a holiday. I have given 6 weeks holiday to patients that come with this problem. Leave the child without a cast till when you wait, what happens? The edema settles. These feet are tender to touch. They won't let you handle, they won't let you manipulate properly, they are tender. So these feet should be left alone. What do? I call the patient after a cast holiday, talk to the parent with the child in the mother's arm, and I try to handle the foot. If the child cries every time I handle the foot, said go back home, come after 2 weeks, because the foot is still not settled, because the inflammation of the slipped cast pressure has not reduced. Give a cast holiday and call the patient back, and then redo the manipulation, which is a modified Ponsati's manipulation. It's a modified Ponsati manipulation. This was analyzed and discussed by Dr. Ponsati in the Clinical Orthopedical Related Research article of 2006. So you can go back and read that, and that's the modified manipulation. Where is the fulcrum? Fulcrum is a tarso-metatarsal joint. So where is the manipulation? Pressure on the metatarsal head and counter pressure on the tarsal bones. So that's your manipulation. That's the modified Ponsati's manipulation. That's the dorsal fingers on the tarsal bones above and the thumb on the metatarsal head that is there. So you do that and you try to give a dorsiflexion pressure. Then you suddenly notice the length of the foot improves, the crease reduces, and the shape becomes better. And you will see when you are casting, this is how you do the casting. You do not do any abduction. Your fulcrum is no longer the talonavicular joint. It is a different fulcrum. It's a different manipulation. It's important for you to recognize this, otherwise you will be in trouble. So after 3 weeks of holiday of that child, you see this foot looks a little better. The great toe has become better. Edema has subsided. We treated with modified Ponsati regime and then got the child back into normal. 8 months, the same child, look at the foot, it's become normal. Just 6 manipulation cast, 4 of the modified and 2 of the other final one. After tenotomy, you get this full correction. 8 months result, the crease disappears. See, this length of the foot is regained, the crease has disappeared. So modified Ponsati regime gets you back a complex foot to a normal foot. But important thing is for you to recognize it, to prevent it first and then recognize it. So key points are prevention, recognition, cast holiday, and modified Ponsati's method, and then do a tenotomy as a regular tenotomy cast. Any questions? How much time do I have? Can I take 3 more minutes? 3 minutes? Okay, I'll take 3 more minutes. Now syndromes. If you look up, search for Clubfoot on a website for syndromes, where would you look for it? PubMed, Google Scholar? You would look for that? Anyone? You need to look at one site, the most reliable site for genetic abnormalities, for any genetic abnormality, and that is OMIME. So what is OMIME? So top of you may not be able to read it. This is a search done on OMIME, Online Mendelian Inheritance in Man, OMIM, Online Mendelian Inheritance in Man. Checking for Clubfoot and the syndromes associated, I get 291 search done about 3 weeks back. 291 abnormalities. Can you imagine? Can you remember 291 syndromes? You can't. So you first recognize is it syndrome or not syndrome from a head to toe examination, and then label it as a syndromic Clubfoot. Then see what you can do, what is recognizable, what is manageable. Don't worry then your red flag of 8 casts to 10 casts is not valid. Then you look at what can you do. After a point, can you do something else to correct this foot? So that's the first one. Top of the list is what? TARP syndrome. I did the search 1 year back, even then the top of the list was TARP syndrome. Okay, the TARP syndrome was the top of the list, and bottom list today is now 290 and there's one more 91. These are rare conditions, I don't even know. You heard about the Freeman-Sheldon syndrome and so many other syndromes are there, Peary-Robin syndrome, so many others are there. But the TARP syndrome with thalipsic coinovirus, atrial septal defect and all these things. The priority then becomes cardiac evaluation and management. So if there is a syndromic child, do send them for a cardiac evaluation. Do send them for an echocardiography. Those are the things that you have to recognize. And then arthrogryposis is a major component. At the times when we were learning, arthrogryposis was just distal arthrogryposis and a little more generalized arthrogryposis. If you look up arthrogryposis now, there are so many variants. We have one of the best experts in the country on arthrogryposis, Dr. Alok is here. I don't want to talk much more on arthrogryposis here, but there are so many different variations of arthrogryposis that are there, which present with a classical ultrasound diagnosis will be there. Fetal akinesia syndrome. Fetal akinesia syndrome, which results from a lack of muscle development, amyoplasia, leads to fetal akinesia syndrome, decreased fetal movements in utero. The ultrasonographers will tell you, recognize that results of arthrogrypotic feet are the most disappointing results. In a study by Jose Marquende of 16 patients with 24-month follow-up, he reported a 25% 2-year recurrence rate. If I were to be asked, I would say the recurrence rate is 100%, provided you follow them for a little longer period. These muscles are not there, fibrotic tissues are there, which do not keep pace with the growth of the bone, and therefore the deformities have to recur. They have to recur. Okay. So that's it. So it's good to have a flexion deformity and clubfoot with arthrogryposis, but it's a challenge to have an extension deformity and arthrogryposis with clubfoot deformity, because this cast will slip out. It's a straight cast, it will slip out. A flexion, you correct this and then correct the flexion deformity. Correct the foot and then correction, just like any other. The number of casts may be more, 12, 13, 14, but it will get eventually, slowly it gets corrected. It gets corrected, but the recurrence will happen. Correct the recurrence also with Ponsati's method, it will still get corrected, don't worry. But in this, you may need to correct the knee flexion deformity, knee extension deformity first, and then achieve knee flexion and then correct the deformity. That's what you do. Here is a child, arthrogryposis, I think it's a 7-year-old girl, tried everything, each time it will come back with a recurrence, and these children walk. They walk with a stiff hip, stiff knee and a stiff ankle. And how do they walk? They walk with a penguin gait like that. They walk with a penguin gait. Stiff hip, so if you watch in Animal Planet or Discovery Channel, that's how the penguins walk. Arthrogrypotic children walk with penguin gaits, and here the mother said, Dr. Sabi, callosity is orient, it's very painful. Can you do something? I had no option but to do a talectomy. I don't do this routinely. I do probably once in a year or something, one talectomy. Very rarely do I do it. I'm not recommending it routinely, but that's the truth. But the 25% recurrence rate, Jose Marconde study. Jose Marconde is a person who stepped into Dr. Ignacio Ponsati's shoes in Iowa. Other syndromes are there. These you can play by the ear. This recurrent edema because of the constriction band syndrome, I had to do the Z-plasty first. I do them myself, correct it, and then corrected it. Here, recurvatum knee, corrected the recurvatum knee, and then got it right. Same child, the scar is there of knee flexion, and this is also corrected. Myelomeningocele, no difference. Only difference is in myelomeningocele, because there is a muscle imbalance, they will need, after the brace protocol of nighttime is over, nighttime and daytime is over, 23 hours is over, you have to give them a AFO, ankle foot orthosis. Or if the quadriceps or something else is paralyzed, they need a larger brace. They need long-term bracing. And if there is a muscle available for transfer, you have to plan that also. But treat them exactly like that. Send them for neurosurgery, corrected it, got it corrected. Diastrophic dysplasia, again a very challenging case. They all have severe bony anomalies which are difficult to correct. They'll keep recurring like arthrogryposis. But each recurrence, treat the same way. Take home messages, try Ponsati in all cases. Many will correct, but even if they don't correct fully, the magnitude of surgery is reduced. Thank you.
Thank you, sir, for your wonderful presentation. So this was third session. Now floor is open for discussion. Yes, sir.
even if the midfoot score, talar head is 0, the curved lateral border is 0, and the middle crease is 0.5 or 0, would you do a tenotomy? No, you wouldn't do a tenotomy. You need to achieve some degree of abduction, because some degree of normal abduction is possible before you can actually do a tenotomy and dorsiflexion. Must be available. So how much is it? It is recurrent, how much is required? How much is required for you to have before you do a tenotomy? It is Ponseti's own video recording is there, which is 40 degrees. So before you do a tenotomy, 40 degrees of abduction should be there in an idiopathic clubfoot in an infant before you do a tenotomy. Okay. So in the older patient, it may be less. So if your abduction after your modified Ponseti regime is not 30 degrees or even 25 or 35 degrees, usually these are older children. They have fast. They have come to you from other centers. They are already 3-4 months old. So there you will do one final abduction cast and then do a tenotomy. Usually one is all that is required.
From the audience?
Any questions? Bracing is 5 years, not 4 years.
Up to 5
See,
years?
Ignacio Ponseti's recurrence rate in the first year was up to the year 80s. Till the 80s, his recurrence rate was in the first year 49%. 49%, that's a huge recurrence rate in the hands of the master. And that's only when review of long-term cases they understood that the bracing is what is preventing the recurrences in these children. So the brace protocol then was extended from 1 year to 2 year to 3 year to 4 year to now 5 years. There is an article which I read, I don't have the reference offhand, which I read that in those patients with these dynamic supinations with repeated recurrences after stopping, you may extend it to 6 or 7 years also. Which means in a child who is 5 years, you would have needed 8 brace changes. That's the average we know from our brace giving that we do. So every child who gets the brace from our center, we know when the brace is becomes smaller and the child has outgrown the brace, we change the brace. So by 5 years, child would have received 8 braces to prevent recurrences.
My question is,
normal. If the child walks barefoot, happily in fact, there is a paper from Dr. Benjamin Joseph which shows that children that walk barefoot have lower incidence of foot problems than children that wear footwears. Maybe Nike, Reebok, whatever.
Thank
they
you.
might sue me if they hear me.
Sir, my query is that up to age of 5 years, patient have
Foot abduction brace, yes.
Brace or after for 5 years after tenotomy. Up to 5 year age.
Just a minute.
For 5 years.
Just please understand this. Once full correction is achieved, that will be only after tenotomy. Tenotomy plus 3 weeks or tenotomy plus 5 weeks in the older patient. From then on, first 3 months you give the 23-hour brace protocol. After that, night time and nap time. Why night time and nap time? Because these children should remember that the brace goes with sleep and sleep goes with brace. Otherwise, they are very intelligent. They will fight, they will cry their lungs out in the night if they are not given a brace in the daytime sleeping time. And until the grandparent or the parent, somebody will remove the brace. ये तो बहुत हो गया, दुखी कर दिया इसने, वो निकाल देंगे. Therefore, you have to give the brace night time and nap time. And rest of the time, 5 years, till the child is 5 years. We don't know the protocols. There is no randomized controlled trial. There is no evidence-based peer-reviewed literature which talks about the brace protocol in the 2 year, 3 year, 4, how long should it be? We don't know. So if that is the question you're asking, I don't know the answer. I don't know if Alok or Alaric can answer that question. As far as I know, there is no such literature. On evidence based on older patients, how long should he give the brace protocol?
Hello, sir. Excuse me, sir. What is the treatment protocol, sir, for recurrence of equinus deformity in a 5 to 6 year old child?
5 to 6 year old recurrence, the same thing, Ponseti.
Equinus deformity.
Ponseti.
Not corrected by, sir, around 5 to 10 cast. only equinus deformity recur in my patient after 5
No,
years.
just a minute. You heard Dr. Alok gave beautifully the explanation. When you have equinus, so when you're standing in equinus, your hind foot is in varus. So
Sir, we start casting initially from.
We cast. Every cast is
supination
supination and abduction.
Supination, abduction.
Every cast is supination abduction. We repeat that. Alok repeated that, and Alaric repeated that.
Still, I am unable to correct, sir, equinus in this patient and refer to your center, sir, on St. Stephen's Hospital, sir.
Sorry?
After starting with supination and abduction casting and already tried for tenotomy on one side and still not corrected equinus in same patient, then refer to your center, sir.
Yeah, no, just a minute. Please understand this. The whole thing, which is example of the towel being wrung like that. It's a twisted towel like that. The example of the foot kinematics. That is natural. When you have a hind foot, whereas the forefoot goes into natural pronation because your foot plantar surface was designed for weight bearing. So evolutionarily we are hard fare for that foot to go into pronation. Therefore each time you have to supinate and abduct. If it is still recurring, you have to repeat the same thing. There is something amiss. Then the base protocol has to be. If there are frequent recurrences, review. Maybe you need to have an X-ray. There was a child in whom surgery was done, came to me for Ponseti. I did Ponseti, corrected fully, recurred. Another went to another person, corrected fully, again recurred, 3 times. Then X-rays were done. Current recommendation, there is a paper in JBJs on this, no need for X-rays in managing children with Ponseti's method. There is no role of X-rays. Here, where previously operated repeated recurrence, then you look at the X-rays. In this patient, I found avascular necrosis of the navicular bone. So growth there was less. As the child grew, it kept recurring. So there are special situations we need to analyze on a case-to-case basis.
My second question, sir, during cast holiday, if there is a pressure sore or pressure necrosis, then during cast holiday, what is the treatment protocol? What is we explain to mothers?
First of all,
what we do for the patient.
The reason we have these workshops.
Recurrences start in these patients.
Doesn't matter. Doesn't matter. A recurrence is any day manageable. It is manageable. We are not worried about recurrences. We are not worried about the foot going. You tell the parents. It will go back, but we will get it back. It always comes back. So whether it is complex clubfoot or atypical clubfoot or it is a pressure sore that has happened, give us 6 weeks holiday. I have told you, I have given 6 weeks holidays. No problem.
Thank you, sir.
Well, sometimes we recommend that if you think that the parents understand it properly, tell them to do it in front of you, not just show it and go. No. It's a psychomotor skill. You have to do it carefully under your supervision and see that they know it, learned it properly, then only. Otherwise, don't.
Thank you, sir.
Thank you, sir.
Since we are running behind the time, we are closing this session. This was a wonderful session with 3 presentations, and on this occasion, I also thank my co-chair, Dr. Harish Makkar sir, and thanks to organizing this wonderful workshop. Thanks all.
Thank you. Thank you so much, sir, Gupta sir and Harish Makkar sir, for chairing this session and all the speakers. Now I request Dr. Vikas Verma sir to felicitate the speakers of this session. Dr. Amitosh Mishra sir. And Dr. Matthew Verghese sir, please. Vikas sir, I would request you to felicitate moderators also. Dr. Harish Makkar sir. Sir, Professor A.K. Gupta sir. Dr. Sanjeev Awasthi sir, please, at this moment, we would like to felicitate. So after these wonderful lectures, we'll be heading to workshop, but we have one lecture before we head on to workshop and skill station. So I would request Dr. Elric Aruzis to give his lecture on
You have the collar mic? मुझे talk next. Okay, so I'm going to cover this topic very quickly. So I'm not going to use slides because I hate using slides. So we're going to talk today about the older child, all right? And I want to just take a poll from the audience here. What is the oldest child that you all have treated? In the audience, or even the faculty here can say, so up to 1 year of age, how many have treated children up to 1 year? That's all. 1, 2, 3, 4. Okay, let's go lower then, up to 6 months. Up to 6 months of age, okay, 1 year, we finish, 2 years, with the Ponseti method. Sorry, I should specify, with the Ponseti method. 2 years, okay. 3 years, anyone? Good, okay. 4, same people, okay. Then I'll make it more now, 10 years, okay. 15, Matthew, what is the oldest you have treated with the Ponseti method? Matthew, what's the oldest you have treated with the Ponseti method? Yeah. Okay, so I think the talk should end there, because what we have tried to say today is that we should be using the word Ponseti method now. We should be saying using Ponseti principles, and I'll tell you why that's important to make that distinction. So it's the same conservative method of treating using plaster. And what we have found that when we first began as a younger child, I still remember this Ponseti course that we had in honor of Ponseti in Iowa, and we had visited him there, where they had the third International Clubfoot Congress, when Ponseti was still alive. And we had asked the same question, what is the oldest patient that you have treated? He said 1 year. And then we said, there were people obviously from Asia and from other parts of Africa, and we said, you know, we see sort of a lot of the older children, this was like almost 15 years ago. We see children who come to us neglected, which we shouldn't be using the word now, but we used to use the word neglected at that time, who come to us from smaller towns, villages, who are 5 years, 8 years, 10 years. Can we use your method for that? He says, I don't know. You have to give me the answer. So he was very honest. He says, I've never done it because in my practice, I see all the young children. My paper, which has talked about the 34-year follow-up, was in children less than 6 months of age. So the person who described the technique had never used it for the older child. And then what happened over the last 15 years, since Ponseti himself said that, many of us went back to our hometowns and said, let's start doing it in the older child. And we began very conservatively. We began saying, okay, let's try up to the age of 1. We found that was successful. Let's go to the older age. Let's try 2, let's try 3, let's try 5. And that's exactly, I think, how Matthew also did it. We didn't suddenly go and jump to a 30-year-old right away. But as we started getting impressed with how the Ponseti method works, because the principles are the same, and if you understand the Ponseti technique, the kinematics of the foot are the same, whether it's a young child or an older child. The biology of the collagen is almost pretty similar, though it's a little stiffer. That's the only difference, that the collagen now becomes stiffer. Dr. Ajay Singh spoke about the fact that there are bony changes that occur in clubfoot. And we used to always wonder that in an older child where the bones are already adapted to that position of equinocava varus, will they be able to remodel? And we have shown that it's also possible. So the message I'm trying to give you that whatever the age of that child or young adult is, don't give up the Ponseti method, because the principles remain the same. The principle of doing it gently, using manipulation, using casting, using molding, working on the kinematics of the subtalar joint, and working on the biology of the collagen will not change irrespective of the age of the child, okay? So how does the method differ than in the older child or in the young adult? If we are saying that we are using the same Ponseti method. So what are the few modifications that we are making? And that's why we don't say we are using the Ponseti method in the older child. We are saying we are using Ponseti principles, because principles don't change. The methods can. So the principles that we are using here in the older child, I'll just enumerate the differences compared to the younger baby. One is in the manipulation. Remember, for the Cavis correction, we said in the young child, you hardly need a few seconds of manipulation, and one plaster is sufficient to correct that severe Cavis. But as the child starts walking, you'll understand that because of the pressure of walking, the plantar fascia becomes very tight. And this is not going to be amendable to one plaster. It won't be amendable to 10 seconds of manipulation, because the plantar fascia is really very tight. So in the older child, you may sometimes have to spend more time in your manipulation rather than just a few seconds. Spend some effort in trying to stretch out the plantar fascia. And for many years, even I was not able to do that. For many years, I used to try 2 or 3 or 4 plasters. Remember that first principle that we said, one plaster for Cavis correction is not true in the older patient. As the child grows older, you might need 2 or 3 or 4 plasters for the Cavis correction. And there are Clubfoot that I've struggled with, where the Cavis was so severe that even after trying 4 and 5 plasters, I just could not stretch the plantar fascia out. And I had to give up and I had to just do a plantar fascia release, which is fine. There's no harm in that, because you're not opening up any joints. Remember, anytime you open joints, you do intra-articular surgeries, you're going to replace collagen with scar tissue. So as long as the surgery is done outside the joints, it's done outside the capsule, it should be fine. So I used to release the plantar fascia. And then recently, in the last couple of years, I've been interacting with some of the surgeons from Africa. And Timothy Nunn is actually a person from the UK who's now working in Cure Hospital in Africa, first in Ethiopia and now in Zimbabwe. And he showed me a technique that he's able to stretch out the Cavis deformities even in the older person, even in adults who are like 15 or 20 years old, by doing a sustained stretch for almost 5 to 10 minutes by the clock. 5 to 10 minutes, and I've seen him do that actually, which I've never ever done before. I used to spend a minute or something trying to do that. So Matthew, have you ever tried that? Spending more time? We haven't. So ever since I started doing that, I've been more successful now helping to release the plantar fascia without the need for a plantar fascia release. But there's no harm that if you have tried and you're not able to do it with 4, 5 or 6 plasters, don't waste more and more time on the Cavis correction. Do a plantar fascia release, which can be done percutaneously. So that's the first difference compared to the younger child. Second is always the number of plasters. It stands to reason that when we said the rule of not more than 8 plasters, we should red flag if it's more than 8 plasters in a young child. In a young adult, obviously this is not true. So you'll find that the first few plasters, if you watch the Pirani's score, it doesn't change much at all. It stays almost like a plateau. And then suddenly the foot starts giving way. Suddenly you start getting a correction. So don't give up in those first few plasters. Unlike in the young child where you see that the midfoot score starts falling very rapidly, in the older patient, it will take time for the foot to respond. So the first 3, 4, 5 plasters will take time for the Pirani score to fall. So that's not the time to give up. That's the time to actually do a few more plasters. So it's not uncommon for these older patients to sometimes need 15 plasters or 18 plasters, which is fine. As long as you can show that there is a change in the Pirani score, you can show that the foot is actually improving visually, then only you should say that I'm not giving up and I'm going ahead with the Ponseti principles. So that's the second thing. The third thing is that I said Pirani score, but remember Pirani score is not very reliable in an older patient. For the reasons, we know it was designed for the younger child. And there are several things in the older patient, like the medial crease. You can't have a medial crease in an old patient. Medial crease sort of goes away. Empty heel sign sort of goes away. So many of those signs which are valuable for the young child are no longer valid for the older patient. So we no longer use the Pirani score, but we use a score called the Paver score, which is very similar to Pirani. Paver is an acronym which stands for plantaris, adductus, varus, equinus, and the rotation of the calcaneopedal block. So it's the same parameters basically, because ultimately all scores are based upon CAVE. So you have different ways of how you're looking at CAVE. You can look in terms of the Pirani score, which is again the same, or you can look in terms of the Paver score. And that has again been devised by the same gentleman, Timothy Nunn from the UK, who's now working in Cure Ethiopia. So that's the third difference, that the scoring system we use, and those of you interested, you can look up on Google, you can find the article which is published, and it tells you how to use the Paver score in these older patients. So avoid using the Pirani score in the older patients. In fact, even in the Cure program, when we have older children who are more than 3 or 4 years, we should not use the Pirani score, but use the Paver score. So that's the third difference. The fourth difference, when it comes to the manipulation, again, everything else remains the same. But the amount of abduction that you can get in the younger child, where we said 50 degrees of abduction before the tenotomy and 70 degrees after the tenotomy, is not valid in the older patient. So the older patient, if you get up to 30 degrees of abduction, because obviously the foot is not as supple, you should be happy with that. So that's the next difference, that you won't get 70 degrees of abduction, you will get about 30 or 40 degrees of abduction in the last cast. The next difference is when you cast the patients, always still use above knee. So you never do below knee plasters even in the older patient. But the precaution you take there is that because you're giving these plasters for multiple times and maybe you require 2 or 3 months to cast them, don't flex the knee 90, but flex it only about 30 or 45 degrees, because older patients will not tolerate so much of knee flexion. They will get stiff very fast. Last thing you want is the adult coming back with a knee flexion deformity. So in these patients, when you give the above knee plaster, don't flex the knee to 90, but flex only around 30 to 45 degrees. You don't need to give a groin plaster in the older patient because it's not required. You can land up in the mid-thighs, whereas in the younger child, we always talk of toe to groin plasters. In the older patient, we can give a mid-thigh above knee plaster, and that should be sufficient. Always reinforce over the over the knee, and always reinforce over the foot. And in some of these patients, you might need to give a fiberglass plaster, because if there's a unilateral club foot and these are older children or older adults and they are walking on that plaster, it's obviously going to break. So this is the only time when we use a fiberglass plaster. And the last thing I would say is that as far as bracing is concerned, the bracing protocol obviously will change, because you can't expect an 8-year-old child to do a 23 hours night and naps protocol, a 23 hours protocol for the first 3 months. So we break that brace protocol for the older child, and what we recommend for the older child is straight away go to a nights and naps protocol, because there's no 23 hours. You can't take a 8-year-old and say, wear this brace for 23 hours. They will shake their head and say yes and go home and do whatever they want, because they're not going to remain in a brace and lie in bed for 23 hours with the brace on. So we change that protocol and we say straight away only use it when you're sleeping in the day and sleeping in the night, which most young children and young adults will sleep for about 8 hours or 9 hours. So you can't have that same protocol that you use for the young child. And in the daytime, we use an AFO for the first 6 months, whereas we never talk of AFOs for younger children. In the older child, we feel that AFOs have a role to play. Ideally, if the child can afford the cost, the parents can afford the cost, it should be an articulated AFO, because we know that we want to maintain all the 3 ankle rockers, and if you block the ankle rockers, the walking becomes very abnormal. But they are expensive, and if you can't afford it, even a static AFO for the first 6 to 12 months is what's required. So these are the few principles of using the Ponseti method in the older child. I would suggest that all of you all who are using the Ponseti method first start using it and get comfortable with a young child. When you know that you can give consistent results in a child who's less than 6 months or a year, where you know you can get 95% success rates, then start venturing into the older child. Begin with the 1-year-olds, the 2-year-olds, then maybe the 5, then the 10. The oldest I've treated is a 26-year-old. And it's the same thing again. But remember that it's not entirely by the conservative method. We are using Ponseti principles, and some of them will need some surgeries. So anyone who stands up and says, I managed to correct a 30-year-old completely without surgery is not saying the truth. There's obviously some surgery involved. What is the surgery involved? As I said, sometimes a plantar fascia release. Sometimes you may need to do an open TA lengthening. Sometimes I need to do a posterior capsulotomy of the ankle joints. Though I don't do it, I know that even Matthew does not do it. What we tend to do is, if you have a severe equinus in an older person, we still do a percutaneous stenotomy and then give serial plasters to bring the foot up from equinus into dorsiflexion. So unlike in the young child, you do a tenotomy and straight away the foot goes from equinus into 15 degrees of dorsiflexion. In the older person, that's not going to happen because there's contracture of the capsule as well. So when you do a tenotomy in the older person, it goes from around 30 degrees of equinus to maybe around 10 degrees of equinus. And then you give serial plasters over the next couple of weeks to bring that into about 10 degrees of dorsiflexion. If you get 10 degrees of dorsiflexion, you should be completely happy with these patients. Don't try to get 30 and 40 degrees. It's never going to happen. You'll be very lucky if you get that in the older person. So these are the differences, in short, between the Ponseti method in the young child and the Ponseti principles in the older person. Suffice to say that whatever type of clubfoot you have, whether syndromic, whether idiopathic, whether young, whether old, always attempt the Ponseti method or the Ponseti principles. You'll be surprised how often you become successful in that. All right? Thank you. Yes. It also grows. It also grows. Yes, but now there's a lot of evidence to show that there is no need. In fact, there are enough trials which have shown that if it's not a degenerative tear of the tendon, if it's a traumatic tear, in fact, people are preferring to do conservative methods in equinus for the tendon to heal, which are now shown to give, in fact, superior results to repairs. So when do we do TA repairs really? We are doing them in degenerative tears, when the tendon itself is of a poor quality, when there's vascular problems with them. So I think the key for doing a tenotomy in the older person, we have realized over time, is keep that percutaneous nature. If you do it percutaneously, remember the tendon of the tendoacheus is very different from other tendons. It does not have a tendon sheath. It's got a peritenonium, which is comprised of vascular tissue and fibrous tissue which surrounds the tendon, and all the blood supply to the tendon is coming from there. If you do it percutaneously like how Ponseti described, it will all heal up. Okay? We are doing currently a prospective study in Vardia. I don't know whether Suresh was part of that. We began after you left. We are now prospectively looking at all our older children in two groups, retrospective and prospective, because we have been doing tenotomies for the last 5 or 6 years. And we looked at all the retrospective cases. The oldest child that we did it was about 8 years, where we managed to get a follow-up. The tendon is absolutely pristine on ultrasound. So we have done clinical, functional, and ultrasound tests. On the ultrasound, in a unilateral clubfoot, you cannot make out the difference between the two tendons except that they're slightly narrower. That's all. But there is a difference in the ecotexture of that tendon. We'll publish it once we get enough number of patients. So we're doing it both retrospective and prospective. It'll be the first study which proves what I'm trying to say to you. Okay? So the tendon will recover. The important thing is, don't make an opening and then do a tenotomy. Don't put a hemostat and pull the tendon out, because you're stripping the blood supply from around it. I think the key why it heals up is because we're respecting the biology of the tendon. Because that sheath and the vascularity remains intact. You agree?
And the conservative treatment consisted of 3 weeks of cast in equinus, followed by a brace protocol with an ankle foot orthosis in slight equinus for the next 3 months, and continued with physiotherapy. The biggest problem of surgical repair of tendoachilles rupture is the problem of non-healing wounds there. These scars do not heal properly, they continue to have discharges. So the current recommendation based on this major paper, 1300 cases, not a small number, major paper is conservative treatment works even in ruptures of the tendoachilles, complete ruptures with gaps. So there are some reports which says that if the gap is more than 1 inch, maybe you can consider some intervention. But by and large, conservatism is the rule for rupture of tendoachilles.
I think a lot of that existing paradigms we had have to change with time, you know. So a lot of things we believed in have to be questioned now, and we are going more and more back to find that conservative methods actually work. There is an urban myth, I don't know whether it's a true story, but apparently how Ponseti came out with doing a percutaneous tenotomy, because before it was always an open tenotomy, is that apparently during the Spanish Civil War, there were prisoners who were captured, and to prevent the prisoners from escaping, guards used to cut the tendons, the TA, so that the prisoner could not escape. And they found that every 6 months they had to repeat a tenotomy because it would regenerate. So that parent story has never been published anywhere. We heard this from word of mouth from people. That's how Ponseti came out with doing the tenotomy percutaneously in children. Okay? So I think start going back and doing it yourself. It's only when you prove it yourself that you'll realize it really works. And once we publish our study, we'll show you unequivocally that the tendon regenerates, even in the older child. Unfortunately, our older child we managed to get for follow-up was only a 5-year or 6-year-old child. We are trying to get those older children, but we have not been able to get them back for follow-up.
A lot of people think that doing a complete transaction, how does it regenerate? You're cutting the paratenon also. But if you really see, when you do a tenotomy, the tendon slides up, the paratenon has areolar tissue connecting it to the surrounding tissue that never slides up. The paratenon remains there. And keeping it closed, don't try to open it. Keeping it closed allows the hematoma to collect under that paratenon and bridge the gap between the two ends of the tendon and regenerates fully. If you do an opening up there and then, the hematoma doesn't collect and it will not regenerate properly. So you need to keep it as a closed tenotomy, and therefore the tendon slides up, the paratenon does not slide up. You can see it. I routinely do operate cerebral palsy children, and I routinely do complete transection of the hamstrings, complete transection. I open the sheath of the tendon, semitendinosus, gracilis, and just cut the tendon. I don't repair it. I completely transect it, and just before, the day before I came, I left Delhi. I did a transfer of that tendon for the same patient who had a recurrent dislocation patella, which had regenerated 2 years down the line, complete regeneration. And I had a full tendon, and in fact I showed my PG. This is a complete transaction I have done, and it is regenerated because the tendon sheath is intact. I have not done a tension meter analysis of the strength, I do not know. But for tendo Achilles, I know they have been able to start walking tiptoe within. I have videos on that. If you want, I can show you that. Videos of 23-year-old girls in whom I have done tenotomies and walking on tiptoe, exactly, nicely walking. Your biggest worry is probably they'll have the calcaneus deformity, incompetence of the tendo Achilles. No, they can walk on tiptoe completely after complete transaction.
Thank you so much, sir. With all the lectures delivered wonderfully, now we proceed to the workstation, where we'll have casting on the rubber foot models and practical session on the bracing and tenotomy. It's in the workstation area outside the auditorium here. So all the delegates are requested to join the tables and interact with the faculty there, and all the doubts in general can be asked there only. Thank you so much.